on Zoom. These hearings that we're doing today, I had a call yesterday that says, okay, what is the purpose of these hearings? So as many of y'all know, 4 years ago, we embarked on a tremendous amount of changes. We did several days, we did actually a number of hearing on women, children, and families, really looking at that in the state. And then also we passed about really 8 large pieces of legislation that had to do with women, children, and families. So 2 years ago, we did a look back to see how things were progressing over those 2 years. And we really determined we needed a little bit more time to see what we had done, had it made an impact, and what still needed to be left to do. So these hearings that we're going to do this afternoon are really going to be looking back at a lot of the changes we made, to see the progress we've made, and to see the things that are still very important that we need to get done again. So, and we're going to look at some legislation. Some of it worked, some of it didn't work. And so we're going to be doing that. So the first person that we have up today is Dr. Dan Edney, and we're so appreciative. Dr. Edney, if you'll go ahead and come on up to the front, and we will go ahead and start. Do you want to come up here? Chad, I'll just come up here.
Thank you, Madam Chairman. Always happy to get to share whatever information is helpful for the work of the legislature. And certainly when we're looking at the health and well-being of families, especially our mothers, our children, our infants, this is core public health work for us at the Department of Health, and very happy to share our perspective of how things are looking. As we look at the health of families, it's important to look at the health of the population, because this includes daddies and grandparents. When we look at the mortality, and I have for you in your packet a copy of each slide, but this is quite a disturbing trend that we have been monitoring at the Department of Health. This is looking at all-cause mortality going back to 1950, which is a reasonable life expectancy in Mississippi. And yes, that is way too low, but that's what it is. And we have been tracking year over year the all-cause mortality for Mississippi compared with the U.S. So the top blue dots are our state numbers, and the lower green dots are the U.S. mortality rates. As you look far to the left, going back into the 1950s and 60s, it looks like we were doing well compared to the U.S., but that's data error. That's not collecting vital records to as robustly as we do in the modern era. So that artificially makes our numbers look better than they are. But as you move into the 70s, 80s, 90s, 2000s, 2010s, and then you see our 3 pandemic years, a very disturbing trend is mortality going up, and the disparity between the Mississippi population and the U.S. population getting wider. And then the pandemic hits, and we had excessive all-cause mortality when you have to include the COVID deaths. And then in 2023 and 2024, our numbers are back down. What's disturbing to me, and that we are studying, we are not back to pre-pandemic mortality rates yet. And even in 2024, and that was disturbing to me. And we don't have clear answers yet why we're still holding at an excessively high mortality rate for the state. But I would challenge you to go before the pandemic to years 2017, 18, 19. Those years were excessively high. So these are things that are important for all of us who have anything to do with health planning, policy, strategy, to understand that the health of the population is not good. And the cost financially to the Mississippi economy, as I have shared with you before, for the 3 leading causes of death plus maternal infant death is about $25 billion a year, negative impact to the economy. But more importantly, these trends here show the negative impact to human capital at over 234,000 people who are not alive today, who should be alive. If we were just average in health, they would be alive. And as we work to pull those blue dots down closer to the green dots, reducing mortality, then we will see a positive impact to the economy, but more importantly, a positive impact to the population. When you correct for the data errors in the 1950s and 60s, and then you factor in babies, children, young people who didn't have a chance to have a family, then really we're looking at more like 330,000 people. And this is not potential, these are actual. That these are people that if they had lived in Rhode Island, likely would not have died a premature death, but they did. And I know all of us in Mississippi do not want this and are fighting against this. But 330,000 people, that's a fifth congressional district, Madam Chair. So this is overall perspective of the population. Then we look at the mamas. Here's our maternal mortality numbers going back to 1950. And, we've lost over 1,000 mothers to pregnancy-related issues over those years. That's nothing, it doesn't compare at all when you look at 330,000 deaths that are excessive. But these 1,000 deaths here are almost all preventable. And many of these had an associated fetal death or infant death related to it. The good news is, and I have for you in the packet, we just released our maternal mortality review committee, child death review, and new infant mortality review committee reports. And it's very important for y'all to understand, those committees are legislatively mandated committees that we administer at the Department of Health. We make sure the data is correct, the data collection is correct. We make sure the data analysis is correct. We generate the report itself, but this is the work of the committee and very important, the recommendations, most of which are to you as a legislature. Those recommendations are from the committee. So as you are studying issues related to mothers, children, babies, please look thoughtfully at the recommendations of the mortality review committees. I concur with a vast majority of those, and we're implementing as many at the health department as we can. Good news, maternal death, we're in better shape than we were. We're no longer 50th in maternal death. We're about 45th. I'm looking for the day where we're 20th in maternal death, but our deaths are down related to pregnancy, meaning that if she had not been pregnant, she likely would still be alive. From the 40s down to the last, the mortality review committee showed for 2022 and 2023, 21 total for both years combined. So around 11 to 15 deaths per year. So the number is way down. The rate is about the same, but our births are going down. So it makes it harder to pull the rate down. And that's another trend that we're watching closely that y'all need to be aware of. Our birth rate is going down significantly. We're down about 1,000 live births, per year. And then some of those live births only live for a few hours and then die. And so they're a live birth that becomes an infant death. I would show you, this is the drive times to nearest OB care in the state. I have it broken down by region that I won't go in detail, but just to show you, the yellow and the orange are deserts for us in the state. This is where women are having to drive more than 45 minutes to care. The darker blue you get, the closer they are to care. And I have it broken down by region so you can look at your areas of representation. But obstetrical deserts are part of our maternal and infant death issues that we are working on at the health department. You can see how really sparse the Delta region is. There's the northern region looks better, but still has some blank spots. Central region, some big blank spots. southern region mostly covered. We actually have our best outcomes on the Gulf Coast when we look at maternal and infant death. Still above the national average, but better than the rest of the state. All right. And I'm happy to stop for questions as you have them. Otherwise, I'm going to plow through. Next is the state of health of our children. I want to thank Dr. Linda Southward, who is at the Children's Foundation, who's been very helpful to us at interpreting the data and helping us use the Kids Count report. I think that's a very important report that comes out every year, very instructive and informative. And this data is mostly from the Kids Count report. So looking at the health of our children, it is not good. Overall, for well-being, we rank 48th in the state when you combine all the metrics that they're looking at. But what was most alarming to me was that our children ranked 50th in the country in overall health. A lot of that is driven by unhealthy weight, obesity, but I've got it broken down for you from the Kids Count report. But when we saw the health ranking for our children with the report, I did invite several government stakeholders together, sister agencies, Department of Education, mental health, some children adjacent service providers like Canopy, Children's Foundation, UMC, Children's Hospital Pediatric Department. Many of us have been coming together the last 6 months. We have our final meeting Monday where we'll be generating a white paper with specific recommendations related to child health that we'll be bringing to you during this legislative session. But what I want to point out to you is remember what you have done and we have done and all of us have done together in education. And so this is the part of the Kids Count report that is wonderful, is that our national ranking was 16th for education. And I want you to imagine a Mississippi in the future where the health of our children is ranked 16th. And what that will mean to the population, what that will mean to families, and what that will mean to the future health and mortality rate for our overall population. Right now, our children are set to continue our trend of severe excess mortality. In fact, I'm very concerned that, especially with the obesity rates in our children, if we don't do something to turn this around, then when they are 40, 50, 60 years old, we will have even worse outcomes than we're looking at today. So the health of our children, to me, is paramount. Y'all did something wonderful in 2007 with the Healthy Students Act. And I've got the provisions, for you of what the legislature expected. I had these, outlined here, but it had more intense nutritional education, increased physical, activity, local school health councils, this several issues that were at the Department of Education, but also down to the school districts. And of course, I don't think any money was attached to it, but I want to show you what got my attention. So looking at 2007 at the beginning, I have in yellow for you, you see the U.S. at the top, you have Mississippi at the bottom. See from 2003 to 2007, that our overweight children percentages went up significantly. But look at 2011, 2012, after enactment of the act and institution of many of its principles, look at the reduction that we saw. But then the implementation of the act stalled and really there's been components of it that continue, like the school health councils, but the core and the nutritional education still is important. And, I highly recommend, but we've got to get back to physical activity being increased among our children. We have got to be working to get these obesity rates down, or we're going to see the health of our children plummet. And I can tell you at this point, our most recent numbers for 2024, it's looking the same. Our obesity rates for the state are like 38% for adults, but then you move into children and we're staying in that 44% range, which is just really dangerous. And the common theme related to the health of the population today is going to be obesity. That obesity is driving the bus for us and a lot of the metrics that's killing the most Mississippians. So I think what you're going to see out of the Child Health Roundtable is putting this act back on the table and let's fund what the Department of Education, our school districts need so we can get these outcomes. Because if we had continued and we were able to continue to show that level of improvement, even if we were just keeping our obesity rates down into the 30s instead of being in the 40s, we'd be making a lot of headway, but we've lost a decade. And we need to get back on track.
Dr. Edney, and I realize that you worked with the governor's office on the rural transformation grant proposal. There are some things in that proposal that would address some of this as well.
Yes, ma'am.
Okay.
And, and it is a big part of the president's agenda and the HHS secretary's health agenda to work on chronic illnesses and especially the health of children. I think that is a significant component of the application, and I think we'll score well. I don't know the budget numbers, but those are things I think we need to be working with legislative leadership to guide the implementation. And I really think, y'all did really good work with this act. We may need to tweak it, but I think this is the roadmap that we have anyway. And to be able to actually fund the act to do what y'all wanted it to do and what it was demonstrating to do those first early years, I think will be very, very helpful for the health of our children. All right, let's talk about the babies. This is our problem. This is of grave concern to me. Maternal mortality is not the crisis that it was. Maternal morbidity is. So thankfully, we don't have the same larger numbers of women dying in pregnancy or related to their pregnancy, but they're still not healthy during their pregnancy and they're having poor outcomes that aren't killing them, but they may have congestive heart failure the rest of their life or kidney failure the rest of their life or have had a stroke that's going to impair them the rest of their life. That doesn't show up on the mortality reports, but we're all studying severe morbidity now. And what we know is that poor maternal health generates unhealthy pregnancies, which generate preterm births with low birth weight. And that is driving a lot of our infant mortality numbers, and it is very expensive. Very expensive. Very expensive for the Medicaid budget because the vast majority of these poor outcomes and maternal deaths and infant deaths, more than 80% are Medicaid beneficiaries. And I always say it's not the program's fault. It's that the program is taking care of those at most risk. And I think the Division Medicaid is all in on working to improve maternal infant health. And I commend them for their vision. But it's also smart economically because as we improve the health of these babies and we're able to move a 22-week gestational age baby from being born and dying, having very little chance in Mississippi to live, to a 28-week gestation by making the health of the pregnancy better, then that baby has a chance at 28 weeks, has an excellent chance at 30 weeks. We lose that baby 30 weeks or more, then we did something wrong. And shorter NICU stays, the older those babies get gestational age, then we reduce the number of NICU days, which are very expensive to the Medicaid budget. Going back to 1950, again, I want to show you, we have made a lot of progress. Back in 1961, when I was born 100 years ago, the year I was born, there were 2,300 other babies that did not celebrate their first birthday like I was able to do. 2,300. Back in the 1930s, we were losing 430 children a year just to measles. But I want you to look at the 1960s, and something really impacted infant mortality. And we did not have NICUs in the 1960s. We didn't have neonatologists to speak of in the 1960s, but something happened that started reducing infant death. That was fighting vaccine preventable diseases. That's when vaccines came online and we were able to help babies and then children survive. And we stopped losing 20% of our babies and children to those diseases. And then something wonderful also happened in 1970, which is another inflection point. And that's when Mississippi enacted Medicaid and improved access to care for mothers and babies. And we continue to trend down into the 1990s. But as you can see, going through the 90s and 2000s, it flattened out despite the advancements in medical science. When you look at the disparity between the pink dots, which are Mississippi, and the green dots, which are the US numbers, that disparity accounts for about 23,000 babies who died who really should not have. That as we can continue to make progress, we'll keep reducing those death numbers. This blows the last decade up for you. You can see going back to 2000, we were running an infant mortality rate right at 11 per thousand, which is extremely high. And then we came down and got down into the 8 range, 8.3, 8.5. But the last 4 years, we've gone backwards. We're running back in the 9s again, which, the US infant mortality rate is in the high 4s. So we're staying double what the US is. But then in 2024, the numbers really jumped on us and our mortality rate went up to 9.7 per thousand. And when you break down the different populations, it's mostly accounted for in the upper left-hand corner with our African-American babies. We've been running very, very high with our African-American babies in the high 11s and low 12s, which is just exceedingly high. But in 2024, it exploded to over 15. So that out of every 1,000 African-American babies born, a little over 15 of them did not survive to their first birthday. We're now trebling the disparity at this point. I will show you, Caucasian rates have trended down in the same time period, not stunningly, but a positive trend down. So a lot of the policies that we've been implementing, when I say we, I mean all of us have been implementing, it's showing a positive trend with Caucasian babies. Hispanic numbers are staying about the same, but the African-American infants are where my major concern is. And that seeing the 2024 numbers, I do not have an answer for that. And I'm not comfortable saying it's the same old. That the things that have been causing infant death the last 20 years is what happened in 2024 because the numbers jumped too much. So one of our part of our strategic plan is working with the communities and talking to the communities to get as much intelligence from the communities as we can. First of all, make sure everybody understands we have a serious problem with African-American infant mortality, and then talking to the impacted communities. What do they think is going on? What are they seeing? And what can we do to mitigate this? And not just assume that from Jackson, we're figuring out why Tallahatchie County's infant mortality numbers are so high. Here is the county by county breakdown. I would encourage you to look at your counties and you will see numbers that are not good. You will see numbers from counties that have outstanding hospitals, OBs, pediatricians. They're better than many other counties, but they're still, almost twice the national rate. The Gulf Coast is doing the best, and it's still too high. I mean, Hancock County has excellent infant mortality numbers at 6.2 per thousand, but that 6.2 is too high. But when you look at let's look at Forest County. Forest County has an outstanding birthing hospital with a, level 3 NICU, outstanding neonatologists, pediatricians, OBGYNs, and they have a mortality rate of 10.3 per thousand, which is very poor. And it's not Forest General's fault. This is the community numbers. And these aren't babies coming to Forest General and dying. These aren't babies from Pike County sent to Forest General. These are all Forest County babies. These are counties of residence. So you can look at each of your counties and see what our challenges are. And these are 5-year aggregate numbers. When we look at infant death and are looking at the causes of them, guess what comes to the forefront? Obesity. So the leading cause of preterm birth in Mississippi is unhealthy weight of the mother. 44.5%. This is according to the March Adams report, which mirrors our numbers very closely. Over 44% of those preterm births, the mother has an unhealthy weight. The next highest is hypertension in pregnancy. Now, this is not just regular blood pressure. This is hypertension related to her being pregnant. Whenever she delivers, most of the time the hypertension goes away. Very, very high risk for women, but only 11% of preterm births are related to hypertension in pregnancy. So just drops tremendously. Even smoking, as bad as smoking is on the health of a pregnancy, is a little bit less than 4% of the preterm births. And then regular hypertension, a woman with high blood pressure who gets pregnant, 5.3%. So all of them pale in comparison to unhealthy weight. And of course, there are some women who have 4 of the 5 of these that really drive preterm births. I mean, you have an overweight mom who has hypertension, diabetes, and who smokes. And that really drives the numbers. So these are the things that we have to target in pregnancy. So that we can improve the health of that pregnancy and hopefully reduce those numbers of preterm births, especially those that are younger than 28 weeks. And we are in very close conversation with the MCOs for Medicaid, who now have a lot of responsibility in the high-risk perinatal space along with us. About these issues and how to mitigate these numbers, but also talking with the private sector, which is extremely important with our birthing hospitals and our OBs. All right, so enough of the problem. What are the solutions? Well, when I saw that we were looking at just egregiously bad numbers for 2024, I called my team in and said, put everything on the table, everything that we're doing, every dollar that we're spending towards infant health and mortality and maternal health and mortality, and let's look harder at what's working, what's not working, what do we need to adjust, how do we need to pivot to impact these numbers, because what we're doing, and when I say we, again, I mean all of us are doing is not getting it done. And I know we're all tired of leading the nation in infant mortality. All of us are. I know you are. We are at the health department. I am as a father and grandfather. Enough is enough. This is fixable. Let's get about fixing it. And so these are the adjustments. This is our strategic plan for infant mortality at the health department. And number 1 is the obstetrical system of care that I've been talking about for 3 years and we've been working on, and here it is. This should go, that's 140 pages of regulations related to our 4th statewide system of care that will follow the trauma system and will help to protect the outcomes of high-risk mothers and babies through the system of care the same way we do through trauma, by taking them to the right level of care, getting them to the right level of care as quickly as we can, and making sure our birthing hospitals are doing all that they're supposed to be doing. I tell folks all the time, we don't have these numbers because we have lousy hospitals, lousy doctors. We don't have enough doctors, but it's not because of lousy labor and delivery nurses. It is because of poor maternal health, and it is because we have a lousy system. Actually, we don't have a system. You know, what we have just organically functions or it doesn't function. But OB system of care will overlay the birthing hospitals and the transportation system to bring the system itself into something workable and measurable. And because you know, 2 years from now, I will be able to report to you where the breakdowns are, what we're seeing in real time, and where we need to be putting our particular attention. The performance improvement component to the system of care will be revolutionary in terms of improving outcomes at the time of labor and delivery and immediately postpartum. Closure of the access gaps, going back to the heat map that had all the yellow and orange and making that more green and blue. We have counties that are never going to have OBs. They're never going to have a birthing hospital. There's not enough population to support it. There's not a population need for it, but we have pregnant mamas who need it. And we take into account our FQHC partners that do a lot of perinatal care. We count that, and we still have blank spots, and nobody else is there, but there's one entity who is there, and that's the health department. So in 2016, the health department pulled out of perinatal care because of FQHC penetration, Medicaid, funding the private sector, and that's where pregnant moms needed to be. But now we see what the care gaps are, and those care gaps are not going to close. So we are standing perinatal care back up in select counties, not statewide, but where at 2 years from now, hopefully I'll be able to show you the same map that will have very little yellow or orange on it. It'll be light green, and we should be able to change that orange to light green by using our network of health departments in the right way. And I truly believe we'll be able to say in 2 years that we no longer have obstetrical deserts in this state. We do not define an obstetrical desert because there's not an OB in a county. Lord, we don't, that's impossible. You know, no state has OBs in every county that I know of. What we need is to have care close enough to a pregnant mom that she's not having to go more than 30 to 40 minutes to receive care. When we get past that, then we're moving into a desert. Do you have a question? Just a minute.
Yeah, Senator England is listening. He's on his way here. Had a traffic there was an accident, so he's been held up. Anyway, he read in a really good question. We look back at that map, there's such a large percentage of the yellow and the orange. Do we know what percentage of the state, his question was, that is actually in the yellow and the orange?
We can calculate that for y'all. I've not done an actual calculation. If you look at counties that don't have an OB, you're looking at over half the counties. You know, I think it's 52 counties that don't have an OB. Part of the solution is workforce, and we do need to embrace family medicine OB. The rest of the country has. Y'all may have to do something with the malpractice carriers in that respect, and perhaps hospitals in that respect. But one way to make yellow blue is to use family medicine OB and to keep leveraging licensed certified nurse midwives to enhance our perinatal care and reduce the amount of yellow and orange on that map.
Dr. Edney, for the committee's sake, will you remind us what the family medicine OB, what that looks like?
Yes, and right now we do have 4 programs wanting to stand up. It's where, a resident does 3 years of family medicine, completes the residency, and then elects to do a 4th year of just OB. And so that 4th year of OB really brings them up to speed to be able to do that moderate risk. We still need our OBs handling the high risk, but we need to be using our licensed certified nurse midwives to help out with those normal risk babies so we can concentrate on the higher risk.
Thank you.
But we do have 4 programs who are looking to open. So we may need y'all's help in terms of adoption of that. Leveraging community health workers. Thank y'all for approving CHWs, because Healthy Moms, Healthy Babies is now going to pivot to a community health worker visitation model, more closely aligned to Georgia, which I'm really impressed with, and following the Georgia model as much as I can, because they are definitely moving the needle in Georgia with their home visitation. And I'm hoping our CHWs with extra training and perinatal issues will help the Healthy Mom, Healthy Baby program be more robust and more sustainable.
Is that program up and running?
January is when regulations for CHW certification goes into effect. We're actively developing the modules for perinatal care and hiring for the health department, the CHWs that we're going to need for home visitation.
Okay.
Hard push to reduce accidental deaths. Half of our deaths of babies are from a sudden unexplained infant death. That includes our strangulation, suffocation deaths that occur from co-sleeping. And we're making a hard push to reduce those accidental deaths through crib and car seat distributions. And the crib distribution is to low income, high risk families that don't have anything, and it's associated with educational safe sleep. So that safe sleep principles or lack thereof is driving a large percentage of half of our deaths that occur outside the first month of life.
Dr. Edney, I want to make sure that I understood this correctly. Did you say half of the deaths are because of accidental?
A large part of them. You can
Okay.
divide our infant deaths in half to though half of them occur in the first month of life.
Right.
A lot of those are chromosomal abnormalities I can't do anything about, but the rest of those are preterm low birth weight babies. And then the other half of the deaths are occurring after the first month of life. And at least 40% of those, that's about 150. So, 40% of that 150 are related to safe sleep issues or lack thereof. So that's low hanging fruit, Madam Chair. And we've, in using the public health emergency, we were able to buy cribs with funding that we already had in a responsible way in a couple of weeks instead of 6 or 8 months that it normally would take. So that we have cribs that are flowing out now and car seats that are going out as we have continued to do. Did Senator Wiggins had a question? Do you want me to stop or?
Senator Wiggins?
I do. Thank you. You saw my hand.
Yes,
Appreciate
sir.
it. Thank you, Dr. Edney, and I appreciate you, your advocacy and what you're doing. And personally, I kind of hope people heard your comments about the vaccines, so I'll just leave it at that. But my question is, when I saw part of this presentation when you did it before the Public Health Committee.
Yes, sir.
And so I've been thinking about it, and if I may, it's more, I've thought about it from a personal standpoint because about the obesity side of it. And, I personally have been on a on a journey, and part of that was just eating better and going to the doctor. And there was foods I'm eating that I didn't know. And sometimes I think that a lot of what the obesity and all is, we just, we don't eat right and sleep right and do all that as a culture. So I wonder, when I see your stats and all, how much of this is related to that. And if I can, I mean, my doctor said my blood pressure was high, and so I did certain things to lower that. So I guess how much of this is, I guess, preventable and treatable from that standpoint, if you can say.
Yes, sir. Agreed. In terms of the unhealthy weight statistics that we see at the state level, is more than 80, it's got to be more than 80% are absolutely preventable. There are medical conditions and medical treatments that drive patients into obese levels, but the vast majority are doing or not doing what you had demonstrated that you're doing. And a lot of that comes through a lack of education, which is why one of the legislative solutions I'm going to have for you is that Healthy Students Act. If we were educating our students over this last 12 years, and MDE has been to the best of their ability, but we need to help them. We need to fund it. Then we can get ahead of this tsunami that's coming at us. But a big part, and this gets outside my jurisdiction, but for y'all to consider in terms of solutions, Senator Wiggins, we've got to look at interpregnancy health of women of reproductive age. Right now, we look at their health whenever they get pregnant and their Medicaid turns on. But at that point, it is too late. They're already overweight. Which
Right.
makes-
And that's what I was saying. And so just a follow up, it doesn't seem, I'm glad to hear about the education side of this. It doesn't seem that the education is getting through to people. I mean, I didn't even know certain things. And I just say that as I would think, I certainly don't, not in a socioeconomic lower level in that sense. And I just wonder, what are we doing wrong, or what do we need to do to get it to sink through? And let me say this, you go to different places like, and I'll just, depending on where you go, like Boston or something, you got people running, exercise, doing those kind of things. And, you don't necessarily see that on the average street around Mississippi. And you said 80% of what you're seeing is preventable. And so how do we make this education sink into people that this is what we got to do?
Yes, sir. We have to do it in a health literate fashion and communicate at a proper grade level and not talk doctor speak to the population. I think most people know that that fried chicken, as wonderful as it is in Mississippi, is contributing to the problem. So as my mama would say, everything in moderation. And so to think that we're going to put every Mississippian on a low carb diet for the next 2 years, obviously it's not realistic. I do want to have a shout out to Medicaid for GLP-1s being covered. And y'all, if we're determined to take fluoride out of the water, which sounds like we're just determined to do, please put money in the Medicaid budget so we can pay for the rotten teeth of the kids that are coming. But if we're going to take fluoride out, can we put GLP-1s in? Putting GLP-1s in the water might help this.
Thank you.
So thank you, Senator. So 5 and 6, I've already talked to you about, and I know I'm short on time, but here's legislative active considerations. And again, please look at the recommendations on your mortality. Those are your reports. Please look at those recommendations. But we will be asking for statutory authority related to fetal infant mortality review. We're doing it ourselves, but we need statutory authority to do it right. And also we need privacy protection for those committees and for the performance improvement work. Public funding of maternal infant health, y'all have done that. I want to say thank you, which is why I have it there. Please don't stop. If we're just going to be asking for level funding this year, we're okay. We can do everything that I'm suggesting. Just support where we are. Please look at health policy that promotes the health of women of childbearing age in between those pregnancies. I'm looking at the Georgia plan where they're targeting women who have had a preterm birth. We know once they have a preterm birth, they're extremely high risk of having another, and they're putting focus on those women in the interpregnancy space. Now, 12 months postpartum really does help that. But, if she's not, we don't want her to get pregnant for 18 months. So I don't want her going without health care for 6 months and being high risk. Number 4, I think we'll be coming to talk about funding, I think through RHTP, but please support Department of Education, Department of Health, other sister agencies working together to develop comprehensive health promotion. I don't want another health class, which is actually what the Healthy Students Act did. I don't want students having to take a health test because they'll hate me. But we can do health promotion 10 minutes a day in school, and over the course of a student's career, they'll come to learn the things they need to know in terms of how to be healthy and what it means to be healthy and what you have to do to be healthy. And then we do need to incorporate repeated increased activity of all the students every day in school. We just have to do that to get these obesity numbers down. Incentivization of high-risk women does work. The evidence is there. So look at incentivizing women to do the right things to reduce their pregnancy risk. Also, RHTP is definitely, that's a Rural Health Transformation Program. That's definitely looking at workforce development, and we need workforce development at all levels. And I think the money will be there to incentivize workforce development, especially in those very rural areas. Facilitate collaboration between state government, which y'all have talked about in the past, and it's working. Many of us are collaborating together. The Child Health Roundtable is made up of multiple state agencies that, that are in that health space. But I would say, really all the HHS agencies work very well together. My colleagues are doing amazing work, and I trust and admire each and every one of them. The FQHCs are a big part of this. Community-based organizations, private sector is key, and facilitating all of us working together, which we have not historically done, and get out of the silos, which we're trying to do. And then support policy changes at the legislative level that will help support initiatives from the Rural Health Transformation Grant that I think, can be a big part of the solution. I think we invest our dollars wisely. We have a one-time opportunity for a moonshot to really attack these numbers. And Madam Chairman, I apologize for going over.
I'm going to ask you one quick question, because something that I want to actually applaud all of y'all on is you, DHS, CPS, Department of Mental Health, and Medicaid have all been extremely collaborative, working together, which you don't find oftentimes. I was in a meeting and they were fussing about different states were fussing about that. That is not what happens here in the state. So I'm very appreciative of that. On that note, we introduced some legislation last year, made it through the Senate, didn't quite make it through the House, that would have given y'all more authority to meet together and then propose legislative changes to us that might clear up some of the bureaucracy that exists. With maybe one agency licensing something, another agency having oversight, different things along that. Would I assume that y'all would still be supportive of having our kind of own DOJ in Mississippi that cleans that up? Absolutely.
Not going to support DOJ. They took 200 million from me. But I can say I do.
Yeah.
I can speak for myself. I've wholeheartedly support that concept. And right now you have a culture among your agency heads where it's organically happening, but that can change very quickly with changes in agency heads. So
yeah, I just want to thank y'all for all
thank you.
collaboratively working as much as possible together. So it's really, it is rare and we appreciate it. So other questions? Okay.
Thank you so much.
This is a great list for us to work on for session.
My pleasure.
All right, Christina Dent, if you'll go ahead and come forward, please. Okay. Christina, will you tell everyone who you are and introduce yourself if they are not familiar yet, please?
Yes, I am Christina Dent. I'm the founder and vice president of mission for End It for Good. We are a Mississippi-based nonprofit that invites people to support approaches to substance use and addiction that prioritize life and the opportunity for more children, families to thrive. So that's what we're after, is solutions that help improve outcomes related to substance use and addiction. Make sure I can get this. It's my clicker right here. Perfect. Mm-hmm.
Would you explain like where you're headquartered and how many employees you have? I'm not familiar with the organization.
Yeah, so we have an office in Ridgeland. That's where I work out of. There are 5 of us on our team, and we have been a nonprofit since 2019. Right. So today I'm going to talk a little bit about helping moms and babies thrive in the perinatal period. So we don't work specifically on that only, but it is part of what we're working on and part of what has come to our attention in Mississippi, in part because of how many moms and babies are struggling with health issues related to infant mortality, maternal mortality, and how many people are struggling with substance use in general in Mississippi. Our use of illicit drugs in Mississippi has about doubled in the last 20 years. That's not the direction that we want to be going in. So I'm going to talk just a little bit about this particular angle because it's relevant to this committee. And first, I want to step a little bit big picture outside of that so that we're kind of on the same page about why people are using drugs. Because if we don't kind of understand that, then we're going to end up with some solutions for moms using drugs that are not actually helpful for them or for their babies. So this is my family. We became a foster family in 2014. This is us in 2017 outside of the Madison or the Canton courthouse, the day that we finalized our youngest son's adoption. He came to us when he was 2 months old. We adopted him when he was 3.5. You cannot be involved in foster care without coming close to substance use and addiction in some way. The vast majority of children in our foster care system are there for some sort of substance-related removal. One of the things that I learned as we were fostering was the beginning of that journey for me of why are people using drugs? Because most of us have just been told like a mom who uses drugs while they're pregnant, she doesn't care about her kids. And we have a lot of that in foster care. So if that's not true, then what is true? What is driving this for mothers? And one of the studies that I came across that I have seen many places since then is this research study that was done looking at the effect of abuse, neglect, and household dysfunction on health outcomes. We've talked a lot about obesity today. Dr. Inez talked about that. This study was actually originally crafted to help determine why obesity was happening among so many people that were part of this health cohort. So there were 17,000 people in the research study. That is a massive research study. And what they found is that the more experiences of trauma that children had in their childhood, whether that was abuse or neglect or household dysfunction, like domestic violence or parents being separated or divorced, the more experiences a child had of that, the higher their risk for all sorts of negative health outcomes, not just for obesity, but for cancer, heart disease, difficulty maintaining employment, showing up for work on time. And one of the things that came out of that is that the risk for addiction increases substantially with every new category of trauma that a child experiences. So a caveat on that, I'm not saying at all, nor is the research saying that everyone who struggles with addiction has had a terrible childhood, or everyone with a terrible childhood is going to struggle with addiction. That's not what we're saying. We're saying we do know what creates risk factors. And we know now that one of the highest risk factors for experimenting with drugs and also developing an addiction, if you do experiment, is the level of adversity you have experienced in your childhood. We could call that toxic stress. I think that's helpful to think of it as toxic stress because when we think of childhood trauma, we tend to think of a one-time experience. But trauma doesn't just impact us at the moment that it happens. It creates this toxic stress that lives in our bodies and often has those long-term, decades-long outcomes in our health. So this is a graph of what those adverse childhood experiences, as they came to be called, does to our likelihood of illicit drug use. So that little blue line on the bottom is if you didn't have any of those abuse, neglect, household dysfunction. If you had 3 of those categories, not 3 individual events, but 3 categories of harm. So let's say you grew up in an unsafe neighborhood, that's an ACE. An adverse childhood experience. You saw your dad beating your mom, and eventually your parents got divorced. So that would be 3 categories of ACE. You are now 9 times more likely to use illicit drugs than the person who didn't experience that. If you add one more ACE on there, let's say your dad got arrested and now he's in jail. Being separated from a parent through incarceration is an ACE. You're now 12 times more likely. With each additional category of harm, your likelihood increases 3x of experimenting with illicit drugs. So why is that? Because we have, in our culture, tend to have been taught bad people are using drugs, and that's why we have relied so much on punishment for it. But it is because the adversity that we face in our life tends to be a little bit like a building storm. So if you face very little, the seas are mostly calm for you, and it's much easier for you to navigate life. If you have increasing ACEs, it's like that hurricane is just building. We're going through tropical storm stage. We're hitting hurricane. That cat level is getting higher and higher. And you're living in that as you age and as you become an adult. And that's not a fun place to be. And often we look for ways to cope with that life that feels so difficult. That's not an excuse for substance use. That's not to say it doesn't matter. People can't, make a different choice. They can, but it does help us to understand why they're making the choices that they are. Because if the thought is that punishing, in the case we're talking about today, punishing pregnant women for substance use is going to make them stop, there's no research that says that that is the case. It actually decreases their health outcomes because we're not addressing why are they using? Why are they risking the health of their child and their own health to continue this? We've got to look at that core reason for why. It's not an excuse, but it does help us understand why. So we can get some relief, but addiction can also increase that storm. So maybe we had a lot of adversity in our childhood. We experiment with some drugs. That turns into an addiction. And now that hurricane just starts whipping harder and harder, not just for the person struggling, but for their families also, and for the broader community. So we end up with this chain reaction of harm. Some of that harm might have started far before that child had any choice about it. It was things that were done to them that created that risk factor. But now we have this cascade of harm, and we have all seen that play out generationally as people experience difficulty that is passed on through those generations as people are unable to have the coping mechanisms to deal with a life that has become very difficult. So what can we do? How can we help, in this case, specifically, women who are pregnant and struggling with addiction? The first is to reduce fear. You can't force a woman to go to the doctor. You can't force any of us to go to the doctor. If you have a spouse that you've tried to force to go to the doctor and they're not interested, it's very difficult. We can't force people into healthcare, but we can increase the likelihood that they will access that healthcare and want to access that healthcare. And the two main reasons why women are afraid of accessing healthcare, specifically related to pregnancy, often they describe as fear of criminal justice involvement or loss of custody of their children. And so the more fear they feel, the less likely they are to go to the doctor and get prenatal care, and the less likely they are to want to engage in treatment and healthcare systems. So substance use is really serious in pregnancy. None of us want children to be exposed in utero to harmful substances. We know that it can increase negative health outcomes like overdose, stillbirth, preterm birth, lots of the things Dr. Edney was talking about. We know that can happen with substance use in pregnancy. So the priority is, how can we help them go to the doctor so that that can be addressed early on at the beginning of that pregnancy and that baby is not exposed all during that time? We can also increase care. So in Mississippi, we do have good access to addiction medication for pregnant women struggling specifically with opioid use disorder. That is wonderful. We need to continue that. If there's any ways we can expand to that and help more women to access that and not to be stigmatized for that, that's really helpful. We only have 2 treatment centers in Mississippi that allow moms and babies to be together while the mom is getting help for her addiction. We had 3 lost federal funding last year, and they had to find new places for those moms in like 24 hours. Incredibly traumatic experience for them. And also family sober living. So we often think about addiction and treatment as a parent helping their child, but we have all sorts of families, parents who have children, and how are they going to continue on working and living if they're going to actually access treatment? So we can increase the number of treatment options for moms and babies, and also family sober living options, more family-centered recovery options that can really meet these moms where they are. And if we think about that a little bit as what is the goal then? The goal is not to carry the stick with a mom and say, go to the doctor. The goal is, how can we create a safe harbor for these moms to come in out of that storm? How can we help them to want to come out of the storm, to feel safe enough to come out of the storm, to not worry that if they pull into that harbor, they're going to be arrested as soon as they get there, or they're going to lose custody immediately without any looking into what's going on in their life? Is that really what's in the best interest of the child? So it's human nature to want to punish harmful behavior, but there's no way to punish moms without also punishing their babies. When mothers are pregnant, their babies are with them and in them. And we are a state that cares very much for the lives of children who are not yet born. The best thing we can do for those babies is to care for their moms and their moms' health care, because as we do that, we get better outcomes for babies. When you look at the research on states that have punitive first policies related to substance use and prenatal or parenting women, they are worse outcomes, not just for the mother, but for the baby as well. And we end up with all those things we're trying to move away from. As we have punitive policies in other states, they've seen more death, more stillbirth, more low withdrawal symptoms of babies. The moms are at an increased risk of overdose, mental health issues. So the challenge of helping babies is that when we come with the stick, the mom and the baby move away from healthcare and we get worse health outcomes. So we want to create a safe harbor. They're not perfect. The storm might still be going on, but how can we draw women voluntarily into the care that they and their baby need? It's not the end of the journey, but those safe harbors can shelter you from the storm and potentially give you an opportunity to change your life. And one of those moms who did that is Joanne. She is 10 years sober now. This is her son, Beckham. He was our second foster placement and came to us straight from the NICU here in Jackson after he was born early because of his mom's substance use, sharing their story with their full permission. And today is actually the 10th anniversary of the day that Beckham came to our home. I was just talking with Joanne on the phone this morning and we were talking about that. So she had struggled with addiction for 20 years and was not able to beat that during her pregnancy with Beckham as much as she wanted to. But she was able to after he was born. She went to one of those 2 treatment centers that allowed moms and babies to stay together. Beckham was able to join her just a couple of weeks after he came into our care. And they have been able to build a life where she has spent the last 10 years helping other people find sobriety after years of addiction themselves. That's not a guaranteed outcome, but the best opportunity for Joanne and for babies like Beckham is to create those safe harbors for them to access healthcare early on so that the mom and the baby can experience better health outcomes as they age. Mississippi is still very torn between competing ideas of how to approach substance use. Should we make the stick bigger or do we make the carrot bigger? And because we can't think about carrots without sticks, I'm going to go with safe harbors because that is really what we want. We want to create safety for women to come forward and get the help that they need because that's the best way also for us to care for these precious children that we want in our communities and in our families. And if we can do that, if we can create more safe harbors, if we can have more women willing to come forward and get help early on, then instead of a chain reaction of harm, we have a chain reaction of healing. And now Joanne is not raising Beckham in a chaotic environment of active addiction. He's growing up in a stable home with a mom who is there for him. And they are helping to break what can so easily become that generational cycle of brokenness and addiction. And instead, with those correct kind of safe harbor for her, she wasn't arrested. Instead, she was able to go to treatment and get the help that she needed. We've got this chain reaction of healing playing out in their lives. And our hope and our dream is that that happens for more and more and more women and children in Mississippi, and all of us benefit when we have more healthy women, children, and families. Thanks.
Do y'all have questions? No, let's do. Oh, okay. Senator McMahon's going to go off subject and ask you a question because you're a foster parent.
Yeah,
But
for it.
I'm going to go back to it in just a second with
Yep.
the question. Go ahead.
Thank you. Thank you, Chairwoman. So, first of all, I want to thank you for your heart of service. I can see the love of Christ in you,
Thank
the
you.
way you help others. I don't even have to ask if you're a person of faith. I can plainly see that. So thank you for what
Thank
you're
you.
doing.
Glory to God.
So, my question is a sincere question. As a foster parent, if you don't want to answer in this room, that's fine, but I would like to have your experience. As far as being a foster parent, did you find it, easy to enter the system? And what was your experience in dealing with the system? Was the system helpful to help you foster, or did you find that it was difficult? And you can use your own words.
Yeah, it is incredibly challenging. No matter what the system is doing, the journey of a foster parent is really challenging. It took me years after we ended our fostering journey because of my husband's employment that the ringing of my phone did not like immediately make me jump, because in foster care, one phone call can change your life. It can mean a child coming, a child leaving, a visitation that happens. So it's really challenging on its own. The biggest challenge for us as foster parents, and this is true in the broader fostering community that we have been part of, is the communication within the system. Because foster parents don't hold any power in the system. We are there to serve children, but you get attached to those children and you see those children and you want to know what's going on and you want to have a voice in that. And so that can be really challenging. But communication within the system for foster parents, the majority of foster parents that we see that burn out, sometimes it is related to the children and how difficult it can be. The vast majority of the time, it is more related to that friction in the system of just feeling like it's so difficult to work inside of that system and to know what's going on. And communication has consistently come up in our experience and many others as kind of the one thing that would really improve foster parent experience is better communication between the agency and foster parents.
So, I don't think it's by chance that you testified here today. From the moment that you contacted the state and you wanted to become a foster parent, how long did it take you to get qualified and to actually receive a child?
It took us about a year.
Thank you.
And that was back in 2014. I think it is shorter now, but we received a child the same day that we were licensed.
And are you still a foster parent?
We are not. My husband took a job that prevented us from continuing on in that. And so we have not fostered. We fostered for several years and then have not for a while for a variety of reasons. I think my husband will be ready to go right back to it again. But
Before you leave today, if you're not staying for the rest of the hearing, would you pass me your personal contact information
Absolutely.
so I can communicate
Yep.
with your family?
Yep. Happy to talk.
you.
Anything's addiction, substance use, foster care. This is my passion. So
Chairwoman,
thank you so much.
Thank you
the
for
committee
allowing
and
me
to
the
Chairwoman
question,
Floyd.
and you'll understand my questions at a later time.
Thank you so much for testifying on this aspect of addiction and actually how that you can with mothers, but also too how successful those numbers can be when you get that intervention. This is something hopefully we will address with some opioid settlement money. I know we have some grants that were presented to the opioid task force, and so we wanted to have you today to kind of talk about the successes you've seen in that arena. So thank you very much. We appreciate it. We have our next person up, if you will come on up, and that is Director Anderson. No, that's Cindy Bradshaw. Thank you, Cindy.
Good. Thank you, Chairman. We welcome the opportunity to be here today to give you a little bit of information about Medicaid. I also wanted to introduce some of my staff that's present. We have Jennifer Wentworth, who's our Chief of Staff, Tracy Buchanan, who's the Director of Health Services, and Amber Herring, who is one of our managers in the services. So most of the things that I'm going to talk to today, they are the experts in this, so I have them in case you have any extra question. And unfortunately, y'all got the short straw and that you got me instead of them today. So I'll try to go through these as best as I can. So the little handout that we gave you, I just kind of wanted to give you a kind of an outline of the population that we serve. And it's just kind of has a breakdown of the children and the ages. And so you can see on here about 66% of the Medicaid recipients fall into the category of women, infant, or children. So just kind of wanted to talk through some of the things that we are doing to try to help in that arena. And so, you know, maternal outcomes has been a huge focus for all of us. And so the new managed care contracts that went live January 1, we required in there that all the MCOs hire a perinatal medical director in addition to the regular medical director that we require. We also increased the ratio for high-risk patients to case managers to 40-1. The MCOs has indicated to us that's pretty challenging for them to hire that many case managers, but we feel like it's important for these women and children to get the services and the care that they deserve. Another item that we've worked on is finally come to fruition is long time working with the Alice G. Clark Center, working with UMMC. They had their open house on that. I think it was on the 28th of last month. And so they have one resident there now, which is a requirement that they have that for then they'll get approval through CMS for them to add additional children there. So we're excited about finally having a place in our state to be able to house these children in more of a family home community as opposed to being in a hospital. Presumptive eligibility is another thing that we've worked on under there was a state law that was passed on that. So what that does is we have so far about 180 people who have been trained on determining eligibility for pregnant women. And so the provider can deem that they're eligible based on limited information, and they are given coverage for up to 60 days while their full application is processed. And so we're excited about that. We've also have really focused on our turnaround with the applications. We've always had a benchmark to process pregnant women applications within 10 days, and we are exceeding that in that we have most applications that are clean applications that we don't need any additional information. We're processing within 7 days. So our benchmark for all applications is within 9 days. That includes the ones that we have to go out and ask for additional information from the beneficiary on. So another item that we've focused on in the last year or so has been high-cost medications that are used in treatment. I'm sure y'all have seen there's lots of medications now that are coming out that are in the $1 million range, and it's kind of been a struggle for hospitals when that medication is embedded in an inpatient stay for the hospitals to be able to afford those medications when it's based on kind of like a diagnosis reimbursement. So we introduced a SPA that allows us to kind of carve out those high cost drugs from what what we're paying for the cost of care, so that we cover that separately. And hopefully that will increase access for those services. And, you know, one of those most prevalent is like sickle cell. There's a new gene therapy coming out for that that's really going to be a game changer, but it's around $3 million for the medication that they need. And so we have some good news on that too. We have on our PPAC program, we increased the rates. You know, we certainly hear frequently from various provider groups that they need more money. The reimbursement needs to be higher, and we are more than happy to pay anybody more money, provided that our budget can accommodate that. So one other area is the Katie Beckett program. It was formerly called the Disabled Child Living at Home. And y'all may know I worked in eligibility for the first 18 months before assuming this role. And that was probably one of the main questions that I got. And kind of in digging into that, there was this assumption that any child that had a disability would qualify for Medicaid, and that's not the case. Just because you have a certain disease, you don't necessarily qualify for Medicaid. So under the Katie Beckett program, there's like two requirements. One, that you have to be disabled, and the other is that you have to meet a level of care, and which basically says in lieu of receiving care in a facility, you're going to receive that care in your home. And that's kind of the whole premise of the Katie Beckett program. There was a family that had a daughter that was disabled, and she was in the hospital, and the mother believed firmly that she could take care of her daughter in her home. Medicaid didn't pay for the services with the in-home care, and after some litigation, that was ruled that would be covered. And so most often when we see people who are denied for the disabled child living at home, it's because they don't meet that level of care where they're not receiving services in their home in lieu of in an institution. And so we just kind of felt like maybe to disband some of that misinformation, if we rebranded it and called it the Katie Beckett, that maybe people would just Google Katie Beckett and read the story and have a better understanding of it. So two other things that we've done with that program is historically that clinical care of determination is required annually. We have decreased the frequency in which that level of care has to be certified. And then we also have discontinued the need for recertification for certain conditions that are deemed to be permanent. And those are like non-reversible. There's no clinical potential for them to change their status and to be approved. And so they will not have to do the clinical assessment after they've been approved initially. So on two other fronts, we have CMS has a division called the CMS Innovation Center, and their focus is just trying to work with the states to implement programs that are kind of like pilot programs to see how they work. And that could be a new reimbursement methodology, various types of things. And so we're excited that we've been approved for two of these grant funding opportunities. We were one of only 15 states selected for the Transforming Maternal Health model. We refer to it as TEMA. That's a 10-year program that we expect that we can get up to 17 million for that program. And so the first year or two of that is really with us submitting data to the Innovation Center for them to kind of give us some baseline information about where we are. And then that's an ongoing process throughout the whole time period. But they are really focusing on things that can improve and kind of testing things to see if they can improve the maternal outcomes and to expand access. Some of those things are just to change the infrastructure. There's some topics in there like birthing centers. They'd like to see more birthing centers, and that is not necessarily a birthing center set up in a desert where there is a birthing center needs to be close by with an acute care facility if something goes wrong. They're also interested in looking at doulas and the impact that doulas can have on maternal outcomes, as well as community health workers, and helping with just health literacy throughout a pregnancy. So, that's kind of the goal of that, is just to improve the quality and the safety that we have. And so the other opportunity that we have been afforded is on the cell and gene therapy access model. There were 33 states that were awarded that based on their applications. And so this is to help give access to treatment for these real high cost drugs. And so CMS, it's kind of the first time, has gone out and negotiated with these manufacturers, not only just discounts on the drug, but quality metrics associated with it, so that there is some money that would be refunded to the states if the therapy does not work. And so one of those very specifically is the sickle cell that I mentioned earlier. We've been working with UMC. It's basically like a stem cell transplant. You go through lots of chemotherapy, and then they inject this into your body. And it, is pretty effective, but for the cases that it's not effective in, since it is new still, if it doesn't work and the treatment fails, they'll have to reimburse us some for the money that we spent on procuring the drug. So, we're excited about that. There's also some funds in there for us to, help with some other things. One, like educating people. I mean, Mississippi has one of the highest sickle cell rates. And there's a long history where some people don't necessarily trust the hospital association with this. And so we're, working with some of the people and advocates in the community that can help get this out in there, because this is a huge game changer, but there's risk associated with it. So in working with UMC, we think there's probably going to just be 2 patients a year that would qualify because of the intensive treatment that it is, and going to kind of start with that and see if it's real successful that we can expand it. It does provide some money for us to help with childcare for parents if they need to come here and stay with their child. It helps with living expenses, if they're not already covered somewhere. So trying to give a very holistic approach to providing help for the family so that they can be supported during this journey.
And the sickle cell treatment, would this be a cure for those individuals that do I mean, is it
It is.
is it curative? Okay.
It's life-changing. The only thing that was a little bit disappointed is that's a hereditary condition, and it could still be passed on. So that's been my challenge to the manufacturers. You need to move a step forward and make this curative so that it's not transmitted to your future family members. And so they're working on that. So we're just not quite there yet. It also gives us the opportunity to hire care coordinators that really help the family navigate through this process. And then it also, gives us money to work with community based organizations and to try to promote this and provide education. So another area that we've been focused on is in the area of autism. We did complete a study on the ABA rates, and there is some increase that is going in December 1st for the rates based on that study. We are still working with the actuaries to look to see if that's enough. But we're also collaborating with the Department of Mental Health's Office of Autism to try to, they have been asked to do a big study of the ABA providers, what their wait lists are like, because there's kind of a rippling effect. Because if we could, if our rates go up too high, that, there used to be a waiting list at all of these facilities, and that could just increase the waiting list. And so we're kind of hoping that when they finish their analysis of kind of what the state of the state is, so to speak, with the ABA therapies, that we'll know what do we really need to tackle. Do we need to tackle workforce development to try to get more ABA therapists? Is it a need for an increase in the rates? Trying to look at it across the board. So
What agency did you say was doing that?
it's the Department of Mental Health. I think it was was it last year?
Yeah, it was last year that we
Uh-huh.
created that agency.
Yep.
So, okay.
So
I mean,
They have hired someone to run that office, and we've had a meeting with her to kind of talk through, we all hear a lot of things. I like to make decisions based on accurate data. And so we're gonna, help work with them to get this assessment together so that we can all make informed decisions when it comes to that. We are also working with the Department of Health on community health workers for pregnant women and how we can expand those services. We're working with the Department of Health on early intervention services to see what changes that we need to make. And we're also working with them on some of the initiatives that we have, like the Premise program and the Healthy Moms, Healthy Babies. So we're having meetings with the health department and the heads of the MCOs and looking at the data that the health department has available so that we can align our strategies to be the most impactful for the moms and the babies who are enrolled in managed care. I know that, I could give you a very long presentation on what all the MCOs are doing, but, they are helping provide safe sleep education. They're providing car seats, provided that members attend a certain number of prenatal visits. They're helping provide transportation, back and forth, breast pumps. One of them is even providing like 14 meals to the family after they've delivered. And so we're kind of excited about those efforts. And so we're starting to see some success in that. One of the MCOs gave us an update on some of their statistics, and I thought these were interesting to include the average gestational age increased from 32.2 to 32.5 weeks. So it's a little bit of an increase. Anything in the going in the right direction is considered a win. The average birth weight, has increased by 2.2 ounces. So that's helpful. The decrease in level 4 NICU utilization went from 45 to 41. So that was helpful. There was a pretty substantial decrease in the newborns that were born between 28 and 31 weeks. It was 21% for the MCO previously, and now it's at 14%. And so when the babies are in this lower risk category, what that equated to is the babies delivered between 34 and 36 weeks. They moved up into that category, and that increased to from 48 to 52%. So that's certainly some good statistics. And so, and then we had a decrease in the low birth weights too, from 33 to 31%. We're also working with the MCOs on some value-based incentives around improvement for any metabolic health, mental health, and the maternal health. Some of y'all may be aware that we have initiated a new program we call the Moms Program. And part of that is the study that Dr. Brett had done showed that a large percentage of the women who die during pregnancy or related to pregnancy are dying after they have delivered the baby, and it's due to strokes and heart attacks. And so, typically when you have a baby, you don't, everything is kind of focused on the baby and not necessarily on the mom. And so we've provided an incentive payment to the hospitals, to the MCOs, and to the physician. So we're asking that the hospital complete a pretty thorough risk assessment on the status of the patient. And if it comes back high risk, that they coordinate getting the mom an appointment with her doctor within certain timeframes, depending on what her risk score is. And that's transferring over to the MCO. So they're reaching out to the mom and making sure that they get to their appointment. And, we've even had, one success story where they reached out and the mom said she didn't have transportation, but she was having headaches, and they made sure that she was able to get to the hospital, and she was admitted into the hospital for a few days at risk for high blood pressure and stroke. And so she ended up being able to come home, to her children. So we were happy about that. Another thing that we're real close to doing as well is there's some genetic testing on babies that are born either prematurely or with some disabilities that are difficult to determine. And they kind of go through a series of tests trying to evaluate what's wrong with the children and try to fix it. Some of them are genetic and just, cannot be, can be helped, but we are developing and pretty close to finalizing our policy to start covering this genetic testing when the babies are in the hospital under certain conditions. It's expensive. It shouldn't be, done on every child, but if the child is in the hospital with complications and the doctors after a certain period of time aren't able to determine what's driving those complications, they can have this genomic test done, and that should point them in the right direction for what the patient needs. So, we've also, and Senator Boyd, I know you asked last year about when I started, about working with other departments. And so we have been working closely with CPS, and I know Commissioner Sanders struggles for placement for a lot of her children, and we have them kind of scattered across the country. And so we did get the list of those providers from her, and our networking team has been working on getting network agreements for those, and that would, once they are covered under Medicaid, she'll stop doing single case agreements, and we can just pay them through the federal match that we get with Medicaid. We are also very focused on making Medicaid easier and simpler to deal with. We're looking at all the communications that we send out to members to see how it could be streamlined to make it more effective and easier to understand. We're looking at, all of our processes that we have where we interact with, providers and members both, to just see what we can do to make those more efficient. We have streamlined the application to make it a little simpler. I'm not sure, I didn't catch all of Dr. Edney's presentation, but if some of this is repetitive, I'm sorry. He and I are working with the Department of Education to try to help lower the obesity rates that we have in children. Currently, we have about 42% of our children are considered overweight and obese, which is higher than the adult population, which is very alarming. And so Dr. Evans has been very supportive and willing to help us with implementing some of those educational components into the school system.
I want to thank y'all. Y'all have done tremendous work over the last 4 years. The whole department has. There have been a lot of work in the arena of maternal health and infant health. And Dr. Britt, we greatly appreciate the work she did on all of this. And making sure that all of these things were written into the MCO contracts and the work that you've done now to facilitate that. So I greatly appreciate too how y'all are all working together. Again, as I'll express that over and over today. The Rural Transformation Grant had a number of components. I know that, and those are being looked at and hopefully approved. But do you feel like with that Rural Transformation Grant and some of the things that have been proposed that we can make a even bigger dent in increasing maternal health care and then lowering our infant mortality? Do you feel like those things are really going to help address some of these things?
I can't point to anything real specific. I know we are working with Dr. Edney to support the OB system of care, which I think is going to have a huge impact on this, and making sure that, because we see it now that, I've had 2 or 3 cases where a doctor delivered a child in a facility that was premature and had plenty of time to send that child and mom to a higher level of hospital, and they did not do it. One of the reasons I'm told they don't is because of this eat what you kill, and that they get paid a global fee for most of that. So with Medicaid on our fee for service, we have discontinued the global fee. They are going to get paid for the services that they render as they render them. And we're having discussions with the MCOs about moving to that methodology as well. So we think that certainly is going to help. The use of telemedicine is a huge component of all of our discussions. And we just left UMC, talking with them about how they can help support the rural hospitals and providers with telemedicine. And so I think there may be some request. That one's big because I think a lot of different insurance payers have different standards for covering that. So we have completed kind of our deep dive to know exactly what we cover and how we cover it and what the reimbursements are. We've asked the MCOs to come and prepare to talk through that with us. We have a list of recommended changes from UMC, and we're all going to sit down and try to figure out what we can come up with that's going to be the best for everybody. So,
Y'all have it, Senator.
Yeah, thank you, Madam Chair. Mr. Bradshaw, thank you for being here. And I have a question that I'm probably going to stumble through, but I'm going to ask it and see if you can, and you can feel free to help me if you see where I'm going. with this question. The presumptive eligibility for mothers up to 60 days. A few years ago, we were looking at this issue of Medicaid very strongly, and what I was hearing from my members in my district, in the healthcare community and otherwise, were these individuals that fall in the coverage gap. In other words, they were making too much money at their job to be on Medicaid, but not making enough to where they could afford to go purchase a plan, even with subsidies available. And so there was that percentage of people that were in that. Are there expecting mothers after they reach that 60 days of presumptive eligibility, that you're finding that some of those mothers are in that, what I'm going to call the coverage gap? And then I want to know what happens to those mothers after you realize that, when that 60-day period is up.
So when we get their full application and we do the verification of income, it could be that they fall out of the guidelines for coverage, and we notify them at that point, and their coverage would end. We would, hope that they would qualify for the exchange program to get it that way, or through an individual product. So, which is a little bit more difficult.
Okay, thank you. Yeah, and this may not have an answer, but what happens if they don't? So they're an expecting mother, so they are very likely to need health care, within that 9-month period of time. They're not eligible for Medicaid, but for whatever reason, they're not able to purchase a plan. What happens to that percentage of mothers? Who bears the cost for the health care that they end up needing?
I would guess some of it's uncompensated care. There's some health departments that can provide help with that. There are some FQHCs that have OBGYN services that they could utilize.
And I'm assuming here, but maybe you can tell me if my assumption is correct. Would some of those mothers be the ones that maybe would have headaches and then wouldn't go get checked out, or maybe have blood pressure issues and wouldn't go get checked out after that? Is that something that maybe we're concerned with?
Likely be.
Okay, thank you.
Thank you, Madam Chairwoman. I just wanted to say publicly how much I appreciate your staff, your administrative staff, especially Mr. Connor back there. He has called me at night. He called me recently on a Friday night at 7 p.m. and resolved an issue for a family that was going to lose their health care on Friday night for a special needs adult that was at home, and a child, a 17-year-old child. They were going to lose their equipment, and they would have died without it. And he resolved it. It was just an error. But each and every time I've ever contacted your staff, even when the outcome was not the way I wanted it to go, I've always been pleased with the way your administrative staff has responded. And you deserve some public credit for that and for the leadership.
We expect.
Thank you. Yeah, and thank you. Thank you for what you're doing, because what you're doing really affects Mississippi families. I mean, it's a life or death situation in many times. So I just wanted to share that with you. You already know my thoughts, but I wanted to take this opportunity to publicly brag on your administrative staff. Thank you.
Chairman, I do have just 3 things I wanted to just kind of mention to y'all on the legislative front. Their ABA therapists are, kind of managed under the Secretary of State's office. There is not a regulatory body that goes in and inspects those facilities. And that is something that I feel like is important. When the legislation, we worked with Lieutenant Governor Hosemann at the time as Secretary of State when he was advocating for this, and we had a study done on ABA therapy. And that was one of the things I told him. My biggest concern was to have vulnerable children placed in care with someone who was not licensed and regulated. So he graciously agreed to take on the licensing component of it, but we still don't have anybody who's regulating that. Dr. Edney has, when I've had conversations with him, he said that he would agree to do that. We have the same situation with adult daycares. We heavily regulate daycares. We heavily regulate hairdressers, cosmetologists, but I just feel like it's real important that we have inspections done. Medicaid does do some inspections on those adult daycares. And we send them, but I can tell you some of the reports that I read that comes back from where we're putting our vulnerable, elderly population is very concerning. And then the third thing that you and I have already talked about is in the realm of surrogacy. Our state does not seem to have any authority over regulating surrogacy. And I've personally been involved with 2 cases where women, I feel like one was being taken advantage of and kind of forced into being a surrogate. We don't offer any protections for the mother, because if the mother finds out halfway through the pregnancy that their child is going to have a lot of disabilities, the parents can just walk away from it, and she's held accountable for raising a child that she may not have been otherwise planning to do. And vice versa for the parents. I mean, there could be the opposite of that, is that the mom could hold the baby hostage and not give it to them. And so usually there's an arrangement too, where the family hosting the child would be accountable for all the medical expenses. And we know that there are cases where we've had women who go into the hospital preterm, they're in there for quite a long time, and Medicaid is paying for those children. And so I do think some protection for all the parties involved in that would be a really good thing for our state.
I think we have the surrogacy legislation. We have a draft of it ready to go. Looking at that, and then the adult daycares, I was not aware of. There was no oversight in those facilities, so we'll look at some of that. And then oftentimes in the ABA, it's a little different because most of those operate oftentimes out of clinics that have speech, OT, PT, that are additional facilities. And I believe that now that board is now housed at the Board of Psychology. It's not under the Secretary of State's board.
It's not anymore.
So, but that's something we'll look at to definitely own those things. So thank you so much.
Thank you.
So we appreciate it. Do y'all need to stand up? Are y'all good? You're good. All right.
Good afternoon. Thank you for the opportunity to be here, Madam Chair. I want to talk to you just a little bit about childcare and then about SNAP, because those are the 2 things I think that we deal with that are going to have the most immediate impact on women, infants, and children, particularly in the next year. Just an update on where we are. You know that when our extra funding that we had been favored with during COVID went away, we lost the ability to fund a lot of childcare certificates that we were able to fund during the COVID pandemic. We now have 19,390 families who are on our waiting list as of yesterday. Now that is families, that's not actually children. There may be more than one child represented in those numbers. We have recently pivoted to beginning to recertify. That's the word we use, Chad. I get mixed up among, is it recertify? Redetermine. Every division in my agency calls reevaluation of eligibility something different. So redeterminations, we've begun redeterminations. And part of the reason we did that is because we're trying to keep as many childcare providers in business, and childcare providers who have a child in their center who is a part of their population that comes up for redetermination for a certificate. If we went to the waiting list ahead of them, then they could potentially put that childcare center at risk of losing that child and that family. So if you heard from any of your constituents about that, that's why we're doing that. We're doing the redeterminations, revalidations at this point. I want to be very frank with you about the numbers. The legislature, when we asked you last year, for $45 million, which was a number we had estimated it would take to stay at the level that we had hit, which was 36,000 children, which is the highest level of certificates the agency had ever funded. The legislature favored us with 15 million of that request. And I want you to understand that we are using that as wisely as we can. We have been able to serve about 2,100 children and families with that. And just so you understand, 2,100 certificates and $15 million. The way the math works is an average annual certificate is about $7,200 per child. If you're in the metro areas of the state, and Mississippi doesn't have very many, but up in DeSoto County and here in central Mississippi and down on the coast are our predominant, and Hattiesburg metro areas. A certificate there runs about $8,200 a year. Out in the more rural parts of the state, at least the non-metro areas of the state, a certificate is about $6,500 for a year. So when you average those, it comes out to about $7,200 a year for each certificate. 2,100 certificates times 7,200 comes to just over $14.2 million. And so that's where most of our $15 million has gone. We're not asking in our budget request for the funding to get back to that 36,000 level, because if we were, we estimate that would require about $60 million at this stage in order to accommodate all of those families on our waiting list. So we've been looking at and talking about some other ways. In fact, the next speaker is going to talk about one of the things we're looking at as a state in order to expand some of our childcare capacity. But we also have built what we call a childcare roadmap, which is a resource for families and parents. We are partnering with the Mississippi State University. We're partnering with Mississippi Early Learning Alliance and the Children's Foundation and Ready Nation, just to give parents, give families a full idea of what childcare options look like across the state, whether it's home-based childcare, whether it's center-based childcare, and the certificates that we offer as well. And I will say I'm very pleased. You have heard, I think this committee has heard from Dr. Chad Allgood before. Chad and his division are doing a wonderful job trying to expand and provide childcare to as many families as we can. One of the really exciting things that we are doing in our childcare division is these, it's called Mississippi Lift, and it's the resource and referral centers. We have located 46 of these resource and referral centers all across the state. And I believe, Senator Boyd, you had an opportunity to attend an open house at one in Oxford recently. We've got some in North Mississippi. We've got them all across the state, actually, down on the coast here in central Mississippi. We're actually working on trying to open an R&R center with the Mississippi Band of Choctaw Indians and have an R&R center on tribal lands if we can. Just to give you a little bit of an idea of what the numbers look like with those R&R centers. And if you have not had a chance to visit one of those, they are a resource for families. They're a resource for childcare directors, for childcare teachers, for homeschooled families, and most of all for children. There are learning materials, there are books that can be borrowed, there are tools, there are toys, there's a little bit of everything, and there's training offered in those R&R centers. So in 2025 so far, we have seen 57,000 visitors, including parents, teachers, community members, and children at our R&R centers. We've seen almost 37,000 early learning resources actually checked out from one of the R&R centers. You can check those out and adapt that to your childcare center and then bring back what you borrowed. We've had 1,650 community events with over 34,500 participants at one or more of our R&R centers. We have made over 2,100 referrals to families for childcare services, for developmental screenings, for early intervention referrals, to CPS, and for child support services, employment services, and for SNAP and TANF eligibility referrals. We've had 1,500 workshop trainings, over 5,800 on-site coaching sessions were completed this year so far at our R&R centers. I'm very proud of those. A little perturbed one day last week when Mississippi State Extension Service had a job fair and they talked about their R&R centers, and I wanted to go get on camera and say, hold on just a second. All of the R&R centers are funded through the Mississippi Department of Human Services, and Mississippi State University is a subgrantee of MDHS, just as Delta Health Alliance. We're very pleased to have them as partners, but as the lead agency, I really would like us to get proper credit when there's a job fair out there, and it's because of an idea that was originated with this man right here. The R&Rs were his idea. His division came up with the R&R centers. And so every time you hear about an R&R center, I hope you'll think about MDHS because they came from our agency. They're funded through our quality money that we use to improve the quality of childcare all across the state. Now, we're also in year 2 of a program called Elevate, which is our new quality rating system. I don't know if rating is really the right phrase, but our quality system designed to improve, again, the quality of childcare offered to parents and children all across the state. And our program, our Elevate program, is really second to none in the nation. There are states all across the country who are reaching out to Chad and his team, asking about our quality program, Elevate, wanting to replicate our program, and it is very successful. One of the other things the Mississippi LIFT program has done, we now offer virtual developmental screenings for children through another one of our partners, Mississippi Early Childhood Inclusion Center down at University of Southern Mississippi, so that parents who wonder about whether their child has a developmental issue, they can get a virtual screening. They don't have to put their child in the car and take them down to USM. They can get a virtual screening, which is a great benefit to families. We are working with another initiative called Nurturing Homes Initiative, designed entirely to raise up new home-based child care providers. And the Nurturing Homes Initiative has recruited and continues to serve 231 new family-based child care providers. And they've had 0 attrition this year. 0 attrition. That's, I think, a testimony to how well that initiative is working. We now have over 21,000 early childhood education teachers who are part of our LIFT workforce registry. And we've entered into an interagency agreement with the Department of Education to align educational standards and coaching between childcare programs and our pre-K collaboratives. And then we've created a kindergarten transition kit in partnership with the Children's Foundation and Elucidata, specifically for families who have children moving on from preschool into kindergarten. And one of the other things we will be launching in the spring of next year, we're piloting something called My Mississippi Adventures curriculum, which was created in partnership with Mississippi State University. It is a dual layer curriculum that provides learning activities and resources for child care programs and includes training for teachers on child development and other early childhood education topics to make sure teachers who are in the child care setting understand what amazing changes happen to a child between birth and age 5, the development of their brain particularly. And then we're working with Mississippi State's Social Science Research Center to develop a new salary scale for early childhood education teachers, because as we all know, those are some of the lowest paid staff in any industry, and we're working to look at ways to maybe increase salaries for early childhood educators. So that is kind of a summary of what we are doing with childcare at the moment. I'll stop for a moment if you have any questions about that before I pivot to the SNAP program.
I had a couple of questions, but I'm going to ask you later on those. So go ahead and.
Okay. All right. So regarding the SNAP program, all of us are familiar with whatever you
Madam
want to
Chair,
call
I
it.
have a question.
Sorry.
Sorry, Senator Wiggins.
Thank you. Bob, thank you. Regarding the childcare, first of all, what ages does that all include, the programs you're talking about?
Yeah, our program serves infant to 5-year-olds.
Okay, so the ones that
And-
y'all are handling, those programs for the childcare doesn't have a educational requirement component to it, does it, or do they?
Well, I mean, there's no statutory educational requirement, but we try to encourage every childcare provider to have an educational aspect to the experience. And let me mention also that we do serve children in the after-school setting, because there are a lot of all of our parents who are in our child care certificate program are working parents. They have to work in order to be a part of the program. And so we also serve their school-age children in after-school programs in some of these child care centers.
Right. Excuse me, right. And so what I'm trying to figure out, and it's actually been here for a while, is how or why or in what way can what y'all are doing work with the collaboratives, which I know you mentioned something about that. And the reason I say that is because the collaboratives that we have childcare component to it, and they require a high level of education. And the part of why the collaboratives were instituted was so that children wouldn't just be in a childcare setting, they'd also be learning on a level that is very beneficial. And so if I understand what you're saying, you know, and we, the legislature, is giving you the money, we've got children in a program that doesn't require education of a certain level. And so how can we rectify these two?
Well, I think from what I just described, Senator Wiggins, what we're trying to do, as I said, is make sure that every child care does have a learning component. There's not a statutory or any kind of regulatory learning requirement, but we're trying to make the handoff from the pre-K to kindergarten be an educational handoff, where the child in the child care center from birth to age 5 is in a learning environment from birth to age 5, and that dovetails with what they begin to experience in the kindergarten and school educational experience.
Senator Wiggins, just to kind of further what Director Anderson has said, the pre-K collaboratives are really looking at age 4.
Well, that's
for the-
correct. Yes. Thank you for reminding me about that. Yes.
Okay, so they look at age 4, and often you may have a pre-K collaborative that goes to 3 o'clock for the day, or some of them finish at noon for the day. Some of the voucher or some of the childcare subsidies that they are giving at DHS actually will go to extend childcare for these individual children. So oftentimes too, like I've just learned today, actually, in a pre-meeting, that Head Start doesn't cover through the workday. In many instances, they're out at 3 o'clock. And so part of what these vouchers are doing is extending that day So the parent can work those additional couple of hours, and do this. So this is kind of picking up oftentimes where the school is letting off, or the pre-K class is letting off, or the kindergarten class is letting off. It extends that work hour so those families can work.
Exactly.
Okay.
Okay,
Does that
that's
answer
fair.
your question?
It does, but I would submit that maybe we need to look at that, that there be an education component, because we know it works, we know it's there. I don't, and I know these are federal funds generally speaking. But I think to have, to just be there. I get we need childcare. I think instituting some kind of educational requirements makes a lot of sense, and the data is proven that it works. So,
Well, Senator, in all candor and giving full credit to what Dr. Allgood and his team are doing, we are committed to making every child care center be a learning center for each child who's there. That's why we're training childhood educators. That's why we're training childhood directors. That's why we last year offered scholarships for childhood employees to go and get certificates in early childhood development. We're doing everything we can to promote each child care center or home-based child care provider as a learning
But-
environment. So we're on the same
no, I
page
know
with
that, but are they of the quality of the high level quality that is in the collaboratives? In my understanding, I'm not blaming anybody. I'm just saying that's been the problem in Mississippi is we get certificates or whatever, but it's not of the high level quality. And like, for example, the collaboratives require an associate's degree for the teachers. So are we requiring in this program teachers to have an associate's degree?
No, we're not
I
requiring
know,
it. Certainly.
exactly.
cer-
So are we going to do, and that's what I think the committee needs to understand. Are we doing this because which is fine for just a place for them to be, or do we want education out of it?
Senator, as some of these children are infants, what we are trying to do is secure, I'll be really candid, this program was designed to help secure childcare
Right.
in a safe environment. So that, and the vouchers, these are in licensed childcare facilities, all are required to be in licensed childcare facilities. So these vouchers are indeed giving the option to parents to continue to work, as the program is designed for a work requirement. And so this, although I understand everything, I think the childcare collaboratives at that 4-year-old stage are fantastic. That is of a different arena and a different educational level for attainment that are needed for that. So I think the purpose, just the quick purpose of this program is to make sure that children are in safe environments, that their parents can feel free to continue to work and continue to support that child economically. As we know, that is one of the great predictors of childhood success, is having a parent that can economically support their child.
Right. And
one more thing. Yeah.
I'll
Madam
just,
Chairperson,
Yeah.
can I make a comment on about the learning environment of childcare versus pre-K? We fully acknowledge that childcare has historically been just a respite care, wipe noses, change diapers industry. Over the last 20 years, we have seen a paradigm shift in that childcare is seen as not just care, but also education. We also acknowledge that our pre-K collaboratives have set up excellent educational environments, which is why just this year we have entered into an interagency agreement with Department of Education, specifically the Office of Early Childhood that runs the pre-K collaborative program. We are setting up standards in our childcare that align with what the pre-K collaborators are doing. But let me comment on the associate's degree point that was made. A degree itself does not indicate that a teacher is going to be successful at teaching a child at birth, at toddlerhood, frankly, and on up. Also, if we were to have degreed teachers in childcare programs, it would set the price of childcare at a level that would be unaffordable for most families in the state of Mississippi. But what we can do is we can approach the learning environment, we can approach the professional development of the teacher the same way that Department of Education is doing with the collaboratives. We are using the exact same quality assessment tool that our pre-K collaboratives are using. Our coaching model, we are aligning our coaching model with the same coaching model that the pre-K collaboratives are doing also. And it's a process. We're gradually getting there, but we've got to set a foundation of making sure that we're solidifying or stabilizing our childcare programs. I would love one day to see every teacher that works in a birth to 5 classroom have some sort of degree. And maybe, and hopefully we will get there, and hopefully we'll get there before I retire, but it is a little bit of a process. But I promise you that we do acknowledge how important the pre-K collaborative program is and how important it is that we align childcare and the pre-K collaborative. So when children are ready to pass into kindergarten, they are as prepared to learn and grow and be successful as they can.
Yeah, that's awesome. And that's real what I was saying, not so much the pre-K collaborative, although that is there. It's the what I call raising the standard of childcare in general, which you've just addressed. So I appreciate that. And I did not know that. So that's good. That's excellent information. Thank you.
Madam Chair, any further questions on childcare? All right, as I was saying, we know HR 1 was passed and signed into law on July 4th of this year, and it made some significant changes to the Supplemental Nutrition Assistance Program, this referred to as SNAP, or some people still refer to it as the food stamp program. Particularly what it does is it creates the reality of a cost share on the part of states. And that cost share becomes operational October 1st of 2027. It's based on the error rate for the state. If your error rate does not exceed 6%, there is no cost share. If your error rate is 6 to 8%, states will pay 5% of the cost of the SNAP program statewide. If your error rate is 8 to 10%, the state will pay 10% of the cost of the SNAP program. And if your error rate exceeds 10%, states will be required to pay 15% of the cost of the SNAP program. Now, those error rate numbers, we have the option as a state to choose either fiscal year 25, which has already ended. It ended September 30th of this year, or federal fiscal year 26, which began October 1st, as the year which will determine our cost share. So we essentially have another year. We have until September 30th of 2026 to try to get our error rate down below, ideally, we'd love to get it to 6% or less, but to get it below the 10% for sure, or the 6 to 8% if we can get there. There is another aspect of the HR 1 that also goes into effect October 1st of 2026, and that is the administrative cost. And since its inception, the SNAP program has been funded 50% by the federal government, the administrative costs, 50% by the federal government, 50% by the state, with 100% of the benefits funded by the federal government. Beginning October 1st of 2026, that number for the state goes up to 75% of the administrative costs. And what are we talking about? We're talking about administrative costs. We're talking about the staff. We're talking about the IT infrastructure, everything involved in administering the program. The state will be responsible for 75% of the administrative costs beginning October 1st of 2026, and the federal government will only be responsible for 25% beginning October 1st of 2026. Every state in the nation is trying to get a handle on this error rate. And I will tell you that there are only about 6 states who are in the 6% or less category right now. And the vast majority of states, about 40 states, are in the 8 to 10% range. Our current error rate is in excess of 10%. So we got a lot of work to do. We have been looking at a number of options, and we have entered into, I'm very pleased to say, some no-cost arrangements with two partners. One is Westat. Westat is a leader in research, data collection, and analysis, as well as technical assistance, evaluation, and communications. Their team is comprised of former Food and Nutrition Service SNAP leaders who know the program. And the scope of work that we will be entering into with them will identify those counties within the state of Mississippi with the highest and the lowest payment error rates, and then try to dig into, investigate the most common error elements and the root causes of those errors. Errors in payment, I want to say this, errors in payment are not indicative of fraud. And that is a misconstruction about what the payment error rate is about. The payment error rate is about how well we as an agency, in working with our clients, perform the eligibility determination function. That's what the error rate is. And the error rate is composed of agency errors as well as client errors. And so we're looking to identify with Westat payment error drivers and the underlying root causes. We're going to review our SNAP policy and our SNAP quality control processes. And Westat will work with us to design solutions once we identify those root causes to mitigate and to minimize those root causes for our errors, and then help us to build long-term capacity for continuous improvement of our eligibility function. The Kellogg Foundation has provided us funding for this project, so it's at no cost to the state. And this will be a 15 to 18-month project that begins in January of next year. We're also working with another 501c3 technology organization called Code for America, and they use human-centered technology to improve public service and make government work well for everyone. That's their business model. What they are going to do with us is help us establish a robust data strategy to monitor, track, and understand, again, the drivers of errors in our eligibility determination function. They're going to help us identify high impact and low cost interventions that we can focus on in order to reduce client-based errors as well as agency-based errors. And then they're going to help us build a roadmap for integrating effective payment accuracy solutions into our systems and into our processes. Code for America receives philanthropic funding. So again, our partnership with Code for America is also at no cost to the state. Senator, did you have a question?
Got a series of questions here. Okay, when we look at error rate, how often, I assume you're really looking at your eligibility, and how often is that done?
Well, we have a continuous quality control function. SNAP quality control pulls a sample every month, and they review a sample, 75 to 100 cases every month. That's a randomly selected sample, so it can be from anywhere in the state.
Okay, and so is that done nationally, or do we have a different metric on that than other state? Are we pulling them more often? Are we pulling them less often? Tell me.
We're pulling it according to the national standards.
So what's in the federal regs on that?
Right, right. Now, what happens is we do our analysis with that sample and we determine an error rate, and then FNS comes behind us and they test our test. They look at our SNAP QC work and they determine whether we, in checking our own homework, whether we got it right. And then together that forms what our payment error rate is determined to be on a month-by-month basis. Let me say this, just so you understand. Our payment error rate fluctuates from month to month because of the composition of that sample. We may have a 4.4% error rate in July, and then in August, we may have a 10.5% error rate. And what FNS is doing is looking at our composite over the period of the entire fiscal year.
Okay, and right now, what would it cost us in penalties if we don't get this correct?
Well,
Based on this, if we're over 10%, what
Yeah,
would
if
this
we're-
cost us?
if we are in the 15% cost share band, which we honestly don't think we will be in the 10% band, but 15% of the cost of SNAP in Mississippi is 240 million. Well, that's if we're in the 8 to 10%. We anticipate if we stay in the 10%, 8 to 10% range, it would cost the state an extra 120 million in the cost share. If we get down to the 5% rate, it would be approximately 40 million, is that right? 40 million. If we can get down to the 6 to 8% level. And obviously if we get below 6, if we get to 6 or below, it won't be anything. But this is a little different. You've heard me talking in years past about our error rate relating to penalties. FNS is not assessing any penalties at this time. They haven't assessed any penalties since COVID. But this cost share, every state will have to assume the cost share beginning October 1st, 2027. If their error rate is, in one of the,
And that total cost share, if we were to get the error rate down where it didn't cost us, what's our new cost share? And this, assuming getting the 75% of admin,
I'm sorry.
taking in that we'll be responsible for 75% of the administrative cost, then our total cost, if we got the error rate down, would be what? Okay,
We can't avoid the additional administrative cost. That $15 million is in our budget request because every state will have to assume an extra 25% of the administrative cost. But if we were to get our error rate to 6% or below, there would be no additional cost share for the state.
okay. And do we have any additional requirements in code right now that make our error rate more difficult or makes it easier for us to make errors than any other state?
Well, I'm going to say this much and really not a whole lot more. We're the only state in the country under change reporting. And change reporting is different from every other state uses something called simplified reporting where they do is it recertifications for EA? Recertification every 6 months under simplified reporting. Under change reporting, our obligation is if there is a $125 change in household income within a month, we are required under current law to recertify that family for SNAP eligibility. If we don't, if we miss that, if it's not reported to us or we don't learn about it during that month, that could count as an error in our error rate.
I would just think that that is something very difficult that $120 is something that is extremely difficult from an administrative point to catch oftentimes.
It is. I
Okay,
agree with you.
that's a pretty low, so no other state has this $120.
$125.
$125. No other state has that. They reassess every 6 months on the simplified reporting, and we have this change reporting of why $125?
That's set by FNS. It was $100 for many years. It went up. I think they looked at the consumer price index and it went up to $125 about a year ago, I believe. So
if I get just if I'm working, which many of our recipients are working at low paying jobs, but if I was to get a week of a little bit of overtime, I could easily stack up this $125, but then the next week I don't have it. Is that
Right.
correct with that?
yes. Yes.
That's a really low threshold. Okay, are there options to go to higher threshold amounts to where it's like $500 or $400? Or did the feds kind of say, you've got option A, option B, you've got simplified or you've got change reporting?
I don't, let me have just a minute.
Yeah. I know we're behind, but are y'all okay? Okay.
Really, it's tied to the consumer price index, so we don't really have a lot of
So we have no,
flexibility to do anything with it.
so we're either need to be in simplified reporting or change reporting. Basically, because, okay. All right. Thank y'all very much for that. Hey, tell me what the overall SNAP budget is.
Yeah, we had 350,000 people on SNAP across the state. Last year, it was approximately $800 million, I believe, across the state was what we
Okay.
put into the economy. Let me say one, couple other things and I'll finish up. We're also running some pilot projects, income verification, as you just alluded to, is a part of our making the eligibility determination appropriately. We're also running some pilots with a couple of other companies that are providing us free, their services at no cost in order to look at, how we need to do income verification and how we can do it more accurately. And I want to mention one other thing because the legislature has supported us in a legacy modernization project, $150 million project. What I'm excited to say is part of that is part of our project will include creating what's called a self-service portal where clients can come online and submit their application for SNAP, for TANF, for child care, for child support. In talking with, and you talked about collaboration earlier, in talking with one of our sister agencies, the Department of Health has asked to join our self-service portal for the WIC program. The Division of Medicaid has asked to join it for their application process. And the Department of Rehab Services has asked to join our self-service portal, which will go live in May of 2027. And all four of our agencies then will be sharing a self-service portal, which will allow clients for all of those agencies to submit their applications at one place and electronically and not having to go in and fill out a piece of paper for an application. And one of the other things that we already know is a root cause of errors. Every time you touch a piece of paper, there's a potential for an error. And if we can do more of this eligibility work online, that will reduce everybody's errors. Thank you, Senator. I appreciate the time. Are there any other?
Thank you. And again, I'm going to say to you too, I appreciate everybody really working together. We've seen a lot of changes with y'all working together so closely. So thank you very much on that.
Thank you very much.
Do y'all have additional questions? Okay. I know we're running late. I'm so sorry. Are y'all ready to come on up? We have Scott Waller and Biz Harris who have been doing some great work on childcare. And I'll just candidly say, we passed a bill 4 years ago for child care tax credits, and they have not been greatly embraced by the employment community as it is out there. So they are going to present to us today some ideas and thoughts on how that we can make sure that we're partnering with business and industry, and hopefully they will take better use of these tax credits. So thank you.
Thank you, Madam Chair, and members of the committee. I want to thank you for the opportunity to speak today about this issue that's become increasingly important as it relates to Mississippi's workforce, and that's access to child care. Business leaders across the state now recognize child care challenges can prevent people from entering the workforce or make it very difficult for them to stay there. This has risen to a top priority among our members at MEC, and this will continue to be something that we focus our attention on as we transition into the Mississippi Business Alliance in January. For those that do not know, MEC, the Mississippi Manufacturing Association, and BIPEC will be merging, and we will be fully integrated January 1 as the Mississippi Business Alliance. John McKay, who is currently the CEO of MMA, will actually be the CEO. I'll be working with the foundation and working on these issues to really help us get information to really help us find solutions to these issues. But as we talk about the issue of childcare, I want to share a few data points with you. Now, many of you have heard me mention these before, but I really believe they're worth repeating because of the real impact that they have. In a study that was conducted by the U.S. Chamber of Commerce in partnership with MEC and the Children's Foundation of Mississippi, we learned that childcare issues affect both those already working and those participating in workforce training and educational programs. Among the parents surveyed, 28% said childcare issues significantly impacted their employment at the time of the study. 11% said they voluntarily left their job because of childcare challenges, and 41% postponed school or training because of those challenges. And more than half had missed work in the previous 3 months due to childcare issues. These numbers reflect impacts on the families, but the financial implications for businesses in the state are significant as well. The study found that childcare issues result in an estimated $673 million in losses to Mississippi's economy each year. Breaking that down, businesses lose about $336 million in turnover cost and another $227 million in employee absences. That's a combined $553 million of lost productivity, retention challenges, and retaining. As it relates to the state and local governments, we see a loss of about $120 million annually in tax revenue because parents are unable to work. Madam Chair, I want to commend you and the members of the committee for taking this issue seriously and for the work that you've already done. As you mentioned earlier, a couple of years ago, there was a piece of legislation passed designed to give businesses an opportunity to get a child tax care credit for assisting employees with child care. We still believe that that was a good start and a strong foundation, but it also can serve as a catalyst for making some needed improvements so businesses will more easily and feasibly use this option. We see the upcoming session as an opportunity to work with you to lower the threshold for the participation and to simplify the process. And again, make sure we do so in a way that strengthens guardrails so there's clarity and accountability. Biz Harris, who is the Executive Director of the Early Learning Alliance, has been one of the many champions. She and her organization has worked to produce a 15-page guideline for employers. Now, look, this is great, but 15 pages is a little complicated, which tells you that there also needs, this highlights the complexity of this issue and some things that we feel like need to change. At this point, I want her to share briefly with you some of the challenges that we're hearing and how we may point towards solutions. Yes.
Thanks, Scott, and thank you so much for having us. And I really want to start by thanking you for the commitment to accessing quality childcare in our state. I think, as Mr. Anderson mentioned, the $15 million that y'all appropriated in the summer, I really cannot state how critical that has been to keeping families in the workforce. I mean, I'm hearing every day from childcare providers that are needing funds, but are also thankful for the ability to keep their doors open and keep those babies in those seats. So thank you. I hope that you will consider continuing that appropriation this year. But we all know that this is a public-private issue. It is not going to take, tax dollars cannot solve the whole problem. It's going to take public-private partnerships, which is why the tax credit is so valuable. We really hoped that people after in 2023 would start taking the child care business credit and using it as a stipend. So basically offsetting the cost for childcare for their employees at their specific childcare programs that their families chose. But because previously it had only been allowed to create your own childcare center, which is just really, burdensome for anybody who isn't Wayne Sanderson in Jones County or Toyota, So we've now had 2 years of real world experience. And actually until last March of 2025, we didn't have any guidance for businesses to know even how to use the tax credit. So I think that's part of the reason why we haven't seen any uptake. But then after working with the Department of Revenue to really write the guidance and say, this is what you have to do. And as Scott said, it's 15 pages long. And that was simplified, y'all. We realized that, and businesses, as I was talking with them, presenting it to them, talking with Rotaries and economic development organizations from Tupelo to Laurel to the coast, they were saying, gosh, we are interested in this. We are excited. We take advantage of every tax credit that we possibly can, especially when it helps somebody. This would help us help our employees and keep people on staff with us. But we cannot understand how to take care of this, especially the mid-size to smaller employers who don't have big human resources teams or big accounting firms. So what we've learned specifically is that the $6,000 minimum, you have to spend $6,000 per employee. That is really just too high for a lot of people to take advantage of. Also, as I mentioned, a lot of businesses do not know about this program, despite the efforts of many, many, many people telling people about it. And the people who do know found it was too complicated. Also, unlike other tax credits that y'all have created, which are really amazing, this one has to be used specifically for employees' children. So there's some additional paperwork and certification that has to be done on both the employer, the employee, and the child care provider, who are often strapped for staff. And then, of course, the amount of paperwork that's required creates a really significant administrative burden for everybody involved. So we really hope that, over the course of the session, we can figure out ways to make this simpler. And the things that, just really quick, for like a list of what the employers and the childcare providers are responsible for collecting just to take advantage of this credit is they have to verify eligible employees and childcare providers. They have to confirm that their providers are licensed. They have to make monthly or annual payments to the providers. They have to keep detailed transaction records. They have to have the certification from the Department of Health, which is a piece we didn't even realize. And they also have to report to the Department of Revenue. So this is a lot of stuff that they have to do just to take advantage of the credit. And while we know some of those responsibilities have to remain with employers, we really hope that you'll explore ways to, one, lower that minimum amount per employee, streamline the requirements so that the credit can be more accessible and practical as an employee benefit. And also I have some very, specific and detailed ways, but I will not bore you with those today, but I will leave you with a little handout. And now I'm going to turn it back to Scott to talk even more like in detail about those things. And again, thank you for focusing on our babies.
Thank you, Biz. And again, we appreciate all the partners that we've had on this issue, because we couldn't do this alone. And it's their expertise that allows us to understand this issue even better than we could as a association that represents our business community. Now, as Biz pointed out, I think there's some changes that we could look at. And I think it may be premature to get into real specifics today, but I just want to throw out a few things as options, as discussion points as we head forward into the new session. But as she just talked about, the current $6,000 minimum contribution per employee can be very prohibitive. And in some cases, the total amount of childcare in some parts of the state do not even equal that. And I think when that's the case, then it's not even, an employer doesn't even have the ability to take advantage of a child tax care credit if you're not going to be able to hit that number. So I think that's something we could do. Again, these are all just suggested options, but things that I would think we could talk through and consider is, lower that minimum to maybe $2,000 per child, but also keep a cap on the tax credit of $3,000. Those are things that, we've talked about. What would allow this would allow the employers to be able to assist with childcare costs. They would share part of the burden, the state would share part of the burden, and more importantly, the employees would maintain a portion of the responsibilities. That way it's shared across all parties to do this. Second, a centralized clearinghouse for eligible childcare providers would give employees the confidence that they need to know that they're working with approved centers and avoid the risk of inadvertently being denied this tax credit. And then third, again, the administrative process, by streamlining it while still maintaining really strong compliance and accountability measures, will be a big part of this ability to use this. Just so you'll know, and I've shared this with the chairwoman, is that we are right now in the field with a survey that we're looking at a statewide scientific poll to better understand what would motivate employers to assist their employees with childcare. This is a 15-question survey that will gather at least 600 responses to give us some certainty that this is data that can be used. We expect these results in the next couple of weeks and believe this will provide additional data to help guide potential improvements to this child tax care credit. The bottom line is this: Mississippi must have a strong, skilled, and available workforce to grow our economy, ensuring that there's access to quality childcare. And again, childcare that includes a strong educational component is essential. This helps prepare the workforce of tomorrow. It removes barriers for parents who want to work today. Madam Chairman and members of the committee, I want to thank you again for allowing us to share this information. Your leadership and your work is helping us secure Mississippi's future, and we look forward to working with you in the months ahead.
Okay, Bryce, I think you've got one. Senator
Thank you.
Wiggins?
Thank you, Madam Chair. And this is more for Ms. Harris for Biz. Which first, thank you for setting me straight on the class rating system for the child care centers. But it sounds like we, the legislature, have created a bureaucratic paper nightmare for the child care tax credit. You said you had some ideas. What can we do better? And I usually like to think simpler is better, and to do that. And can we do something for the parents' side of the equation?
Oh, thanks, Senator Wiggins. So I think, I'll definitely email you the document, but I think ultimately, something very similar akin to the pre-K collaboratives would work very well. Having one entity that in different regions of the state that's responsible for
For
helping
the
gather
record,
that.
Madam Chair, I didn't ask her to say that, of the collaborative.
Well, I think it works really well, right? In terms of the pre-K collaborative serves to recruit people to take advantage of that tax credit. It also serves to gather the paperwork from each partner and then put it, and then get it to the Department of Revenue. So it works really well. I don't think we need quite as many for this. Like, it could be a regional sort of hub or entity, but really that would sort of minimize things. I also think in the same way that actually an HR provider works with different cafeteria plans and health benefits, it could sort of work to benefit in that way. So it would streamline things, it would simplify things. And I actually don't know that the cost would, I think cost would be minimal, if anything, if zero to the state.
Thank you.
Thank you.
Additional question?
Yeah.
Senator?
Thank you, Madam Chairwoman. Hey, first, I do want to thank you guys for taking time. So I represent Lee County, Mississippi. The district I represent is the heaviest industrialized county in the state. It's one out of 5 people still work in manufacturing in Lee County. Now, I know my colleague here is Jackson County, and they are also heavily industrialized. But if you took one employer out of that district, the area I represent would have more than 10,000 manufacturing jobs to any other county in the state. So I want to compliment some of our corporate partners like North Mississippi Medical Services. They have found, by having a 24-hour child care center, it allows their healthcare professionals to come in all 3 shifts and support their team. Also, Toyota Manufacturing North America has put in a facility, as you are well aware of. But this is a vitally important issue, and I'm hearing from many constituents who have lost the voucher because of federal tax changes, and I'm also hearing from businesses that want to implement some type of child care tax credits, but it's too sophisticated, too complicated. And so I don't have the answers, but I would be willing to hear anything you have to share, whether it's here or privately, anything we can do to help single parents who want to work, who want to utilize their skills and their degrees and their certifications to help them find a path to get to work. And so any ideas that you guys can bring forward would be very helpful, and I yield.
I'll just comment and say that you're exactly right, that having these these folks in the workforce are very, very important, particularly regardless of the sector that they're working in. And I think that as we talked about helping streamline this, and we're very fortunate that we have companies that can provide that. But I think one of the biggest challenges that we're facing today is the traditional childcare center that opens at 7 in the morning and closes at 6 in the evening doesn't necessarily fit every worker's needs as they exist today. So again, these are things that as we look through this process, how can we maybe find ways to make that more of a focus that we look at? But at the end of the day, I think if we build on what you've already started and try to get it so it's more, as we said, easier to use, things we can do, that's going to help us move to that point to really kind of focus on some of those other needs that we're seeing that employees have to ensure that our employers across the state have the workforce they need.
Thank you both for this great information. And I'm glad that our sister county up there, Lee County, with the industrialized jobs is going to benefit from this. I know we will in Jackson County as well, and everywhere. But my question is, with when we passed this bill to allow the child care credit, one thing that I remember we did was allowed for off-site locations. And the idea was or I guess the hope was that this credit would help fill some of these child care deserts that we're seeing where we don't have that. Is that something that the Mississippi Business Alliance could help relay to employees and to communities? Once of course, we've got to deal with some of the bureaucratic issues we've created, which we're really good at doing, apparently. But once we get that, I think the publicizing that is something you guys could help with, because ideally we want to see more child care facilities pop up in communities, especially where we're trying to attract new industry and new businesses, and also help with our large employers that are already in place, because that is something that I hear about from my constituents, is that we just don't have enough child care facilities available. So that was our hope, at least mine, when I voted in favor of this legislation, was that we would see some of those pop up more. So are we seeing that happening already, or is it something that we hope to happen?
Well, I think there's a strong interest within the business community to address this. I think to your point, if we can go back in, and again, these are things sometimes that are very technical, sometimes they're really just simplifying. As we work through any changes that is made to the legislation or the current law, there's no doubt that what we will need to do is make sure we are making our businesses aware of this, because that's the only, if they don't know about something, they're not gonna be aware of it. If they do, if they realize there's a benefit to it, that's what we want to do. We want to see this become something they can offer as a benefit to their employees. And again, to your point, we do realize there are certain parts of the state where there's less opportunity, less access to childcare. So those are some things that maybe, we can kind of address as well. But at the end of the day, we've got to make sure that our business community is aware of this and how they can take advantage of it. So yes, we'll be working with you on that.
Okay, thank you. And I want to commend you all for that big change that we've seen in our business community by moving to the Mississippi Business Alliance. I think that's going to be a great thing. I'm glad that you guys all kind of pulled your resources together, and I look forward to the great things you guys are going to be able to do with that.
I'm excited about it too, and I think it's going to be great for the state and great for our businesses.
I just want to add one thing to your question about promoting it too. I mean, goodness gracious, MEC has been an incredible partner in championing it in the business community. I lead the Mississippi Early Learning Alliance, and so we prioritize and have a coalition of about 230 people across the state focusing on infants and toddler issues across the board. But I want to say that we have been working with the Department of Human Services and Ready Nation and the Children's Foundation and MEC to actually create a toolkit, not only to help people take advantage of the childcare, of all the different tax credits related to early learning and childcare, but also to show what's available in terms of creating, to help people understand, specifically the business community, how to understand how to launch a new childcare or partner with a childcare to grow your seats. So that's coming, and it's going to be called a roadmap. And I'm really excited about that. Sort of we've all been working together to make that change.
Yeah, thank you. And thanks for everything you've already done, because I know that in our seats, a lot of times the expectation is to see results kind of quickly, but we understand that that's one that is going to take some time to see that take place. And I hope I speak on behalf of most of my colleagues that we're willing to be patient and let that kind of grow out, because I do think we're going to see those results by providing this tax credit. And if we can fix that to where it's easier to use, I think that's going to be a big benefit for everybody.
Thank you, Madam Chair, and thank you all on the committee for taking time to gather what I think is really, really important information for you to have before we make decisions that impact the lives of children and families in Mississippi. I've listened to all of the presentations prior to mine, and I would say that, as I've said to you many times before, I have the largest data pool of children in the state, and I think as we explore what's happening with those kids, it gives us a really good indication of where we have gaps and, where systems are improving in the state. The primary reasons kids come into custody are mothers addicted to substance abuse, parents, substance abuse in the household. Senator McMahon, Lee County. We are really struggling up in Northeast Mississippi with pervasive substance abuse and lack of treatment. There is nowhere for a mother to go with her child and get clean. Dr. Edney didn't say this today, but he and I've had this conversation many times. And there's a window of opportunity when a mother in that first trimester, the last trimester before the baby's born, and then the first trimester after the baby's born, there's a window of opportunity for getting clean. Her hormones do some things that make it, a really optimal time. And instead, in Mississippi, we're really just using the child welfare system to address that. And it's not a very cost-effective way, and it's not a very efficient way to address some of these bigger issues in the state. Housing is at a crisis level, lack of housing, I guess I should say. And parents who don't have shelter really can't think about things like being a good parent. We're talking about very basic needs for families. Childcare. I can't say enough. Ditto to everything they've said. Kids who are in childcare mean parents are working. Families are much more stable when parents are working, and we have better outcomes for our kids. So I commend all of my colleagues on the work that they've done, and we are starting to see some data move in the right direction. Is this the clicker thing? Okay. So I focused on the last 5 years. That's the amount of time that I've been in my position. And we've seen progress. We also know that we have more work to do. We're really focusing this year on getting our technology modernized and using data to drive decisions rather than, just guessing at what the problem is. Y'all know we've been working on this Pathways case management project now for 3 years. It is like pulling teeth and reining in Clydesdales. I'll make the point again, it doesn't pay to buy the cheapest vendor as we do in Mississippi. But I have a great project management team. We think we will be able to deliver a functioning system, but it has been a really, really difficult process, and we're not there yet. So right now we have a target date of February. We are testing the system. End users are testing it, and it's not going as well as we would like for it to. So The one thing I commit to you is I will not close out that project, and I will not roll out a case management system that I don't have complete confidence will serve the needs of our staff and keep the stories of our children from front door to back door. So we will keep at it as long as it takes. We finally were able to procure a shorter build for a bidirectional foster parent portal. I heard Christine comment earlier about the difficulty of becoming a foster parent. We're aware that that needs to be lots better. That is one of our bigger challenges that we've not yet been able to tackle. Technology is one of the ways that we are focusing on making becoming a foster parent easier, staying a foster parent easier, and using the agency's resources to wrap around and support foster families rather than putting up barriers. Couple of things this fall that have really are starting to turn the needle. I had to make a big leadership change. We are finally starting to get our numbers down for timeliness of licensing. I can tell you that my data is sporadic because there are some backlogged cases that have been taking entirely too long to license, but we are getting those through and should be able to show some much better data in the spring. We are going to use that parent portal to have a transparent list and an orientation packet. This is what you need to know to be a foster parent. You can take a picture of the documents that we need from you and upload them into that portal with a timestamp so that we're not shuffling paper back and forth and then saying, we don't know where your most recent bills are. So, the dashboards that we have built internally, we've really focused on using data, even though we don't have our new system built, taking what we have. We've built out internal dashboards that have allowed us to really make a lot of progress on getting the number of caseworkers where the children are. And y'all have heard me talk about that before, but the slide down at the bottom here, we went from 46% of our caseloads meeting the Olivia Y standard, which is a pretty stringent standard across the country. It's about 14 children to one caseworker. Today, we are enjoying and for the last 6 months, we've stayed over 80% with our caseloads meeting that Olivia Y standard. And more importantly, 94% of our caseloads meet a nationally reasonable standard. So we're seeing our efforts pay off in stabilizing the workforce. You can see up there on the turnover rate that we went from around 33%, and we've been able to hold steady at around 23% on turnover. This is hard work, and it's hard to keep people. And then importantly, on the financial front, that penetration rate up at the top, I've educated y'all on, the complexity of drawing down federal funds. Mississippi has gone from around 32% to 45%. The state never saw a penetration rate above 40% until the last 5 years. And we've never gotten above 62% on caseloads meeting the Olivia Y standard. So those are where we're seeing some fruit from our labors. Ignore this. This is not the right slide, but I will point out one thing on here. We want it all, actually. But what I will tell you is that we have finally, I told you all starting in June of 2023, we saw an influx of children that was unprecedented and didn't follow our usual data patterns. And we steadily had more children coming into custody than left for a year and a half. That resulted in us having over 4,150 kids at the high water mark. We did start seeing in September of this year, our exits have really started to outpace our entrances. We're still getting the same number of calls. We're still bringing the same number of kids into custody. But the big difference maker is that we have started we have attorneys in some counties across the state that are dedicated solely to the agency's practice. They are working with our staff in the county office in preparation for court. They're entering agreed orders with prosecutors. And we have cleaned out hundreds of cases that have sat for too long in the court system because action was needed and there's nobody driving the case. So it's been a combination. You guys gave me some ARPA money that we put to good use. That will come to an end in May. The Attorney General's office has joined forces and worked with us on that. And so I've got some great data to show you the impact that that's had on how long kids stay in custody with us. And we want every kid in custody that needs to be there at the right time for the right amount of time. So it's not a goal to not have kids in custody if that's where that child needs to be, but it's a serious intervention on behalf of the state. It does some harm, and we want to use it when it needs to be used, when a child's safety risk outweighs the harm that we know will do when we pull them out of their household. We have made a lot of progress on training our workforce beyond the basics of what's required in Olivia Y. We've had a lot of partners help us with that, human trafficking with the Attorney General's office, trust-based relational intervention, trauma-informed training that we've worked with CASA on the coast to bring to Mississippi. And you can see some of the others. Car seat training, the Department of Health has partnered with us. And I think you heard Dr. Edney say that preventable accidental deaths are one of the higher causes of our infant deaths in Mississippi. And just to, this probably wouldn't shock you, but the highest number of kids that come into custody for their safety in Mississippi and across the nation is kids 0 to 5. They're the most vulnerable. And 0 to 1 is really very, very vulnerable. And it's where we have the most deaths. And then just quickly, we also use the funding you've given us to invest in older youth. We've implemented a driver's license program through Sunnybrook, and 165 of our kids as of the summer had gotten their driver's license. I think that's a fundamental skill for life, and that if we send them out without the ability to even transport themselves, we're failing them. We've also increased the number of supervised independent living beds. Those are expensive, but the stats for my kids are not good. 70% end up incarcerated or homeless or both. And that's nationwide. That's not Mississippi solely. But when we get kids through that transition period of helping them navigate from 18 years of age, I would say up to 26. I'd love to see our state invest more in supporting those older youth. Then they get jobs and they become functioning citizens, and they make some of the most resilient, scrappy, tenacious people. I have many that work for me. So I thank you for that investment, but I hope that we can do more. This is some of the data that I think is really important in terms of like the adoption rate, the amount of time that it's taking to get kids adopted. Right now we are, well, this one doesn't show that, but just this is a hard number of how many were adopted in 2024, how many in 2025. Those numbers are a little bit lower than what you were seeing back in the 2017, 18, 19. That's because Mississippi had a huge backlog of kids that had been sitting there legally free for adoption for a long time. And we also had a lot more kids in custody. We had over 7,000 kids back in 2016, 2017. This year we're on pace. We've really focused on cutting down the amount of time it takes to get a kid from once the plan has changed to adoption, getting them through TPR and adopted swiftly. We've done 276 so far this year, which puts us on target to have about a 10% increase in the number of adoptions. This is what's more important to me, though, is the amount of time that it takes to get a child from custody to adoption. And you can see in 2020, it was taking about 1,236 days. And that number's come down to 912 days. And I totally credit that to this effort with attorneys and bringing better consistency to the practice in the courtroom. Custody reunification, we've also brought those numbers down some, 433 in 2020 to 370. And we're really focusing on keeping kids safer in the SIP. We launched the youth court attorney program. The longer kids stay in custody and linger when they don't necessarily need to be there for their safety is when the state has the most exposure. Things go wrong. We've also implemented this year a maltreatment and care and fatality review committee so that we have a high-level multidisciplinary group looking at every single incident that comes through. We're gathering data and informing practice from that work. We are partnering with a national safety coalition that's out of the University of Kentucky to bring more data to our decision-making as it relates to investigations and evaluating risk. Department of Health is helping us review fatalities on a quicker basis. All fatalities are reported under law to Child Protection Services, or they're required to be. They don't all get to me. But so even if there's not an allegation of child abuse or neglect, they're reported to the agency and we investigate, but I don't have a medical director. So I work with Dr. Edney closely to try to, instead of just to use their capacity and their expertise. Our legislative priorities, I believe that attorneys in the courtroom will pay for themselves based on what we've seen so far, at least 3 months shaved off the average length of stay in the counties where we're applying the program. On average, sorry, it's not each county. I believe a uniform youth court that's constitutionally has the authority to hear all cases start to finish in the youth court that impact children would probably change the state more than just about anything else you can do. And we're going to be asking you, we've got some tweaks to statutes to try to enhance the central registry and make it more accessible to get the right people on it, because we're really struggling with, we're not getting anyone put on the registry right now. It requires a court order after conviction of a crime. And so that's really, really late after we know we have someone that really doesn't need to be hired as a teacher and doesn't need to be hired by me to take care of children. So we'll be working with you on some change in language where we could have someone added after a TPR is prosecuted, and just at a lower bar so that we're not all missing the boat on foster parents and childcare workers. I think, well, that was an estimate of cost. We can draw down federal reimbursement for attorney representation. It's not a significant match, but as you look at adding a volume of attorneys, it ends up being about 25%. So I'll open it up for questions.
While you're on that thought, you've given a stat before, and I'm failing to remember it exactly, but for every amount of time you've given it that we say that we don't have a child in custody, the state saves X.
Yeah. Based on the census we have right now, it was really based on that 4,000 kid census, but we're at 3,846 today. But I'll give you a rough idea. If you could shave off unnecessary months, so 1 month on the census we have right now, provided the kid doesn't need to be there any longer for their own safety, you'd save about $13.3 million. We've had to recalculate our average cost per child. It's about $48,000. Now we do draw down federal funds for that, and that's where that penetration rate going up to 45% is so important. But we're also bleeding a lot of state cash on placements that, kids who are going out of state for treatment that's not available here in the state or that's been denied to those children. And I've done a lot of work with Medicaid to try to enter some contracts with those out-of-state providers. So we're at least drawing down the 75% match from Medicaid. And then we are also working with them to cover some of our prevention services that we brought in on ARPA funds, and we need for them to be sustainable. I believe that's the other key to how we've been able to slowly and safely start to move kids out of the system at a pace that is getting closer to national standards. And so
How many kids do we have in out-of-state custody right now?
right at 50.
And do we hope once Canopy gets completed, once the Alice Clark facility gets to where it's fully up and going, do we hope to lessen that number?
We do. Alice Clark had taken their inaugural patient, and it's one of our patients, but that child was already living at UMC, so it's not pulling one out of state. There are 2 others that have been identified in the first few admissions of ours that will come in from out of state. So we're very excited about that. And we've been chipping away at the problem from a lot of angles, but working with the MCOs and getting better accountability. We're working with Medicaid to draw down federal funds so that we might hire a targeted case management group that would be able to sort of better manage our lives and their coverage. So, if I'm getting multiple denials from one facility, really starting to look at those trends, and let's look at, do we need to push back legally? Do we need to start appealing in a different way? But right now, we're holding steady at about 50 out of state.
Okay, the other question that we always ask is how many kids do we have right now in hotels?
I have that graph for you. We have 22 kids in hotels today. We saw an alarming increase in number of kids that we had to put in hotel situations. And just for clarification for the public, this is, we are contracting for a hotel room, and we are contracting for full-time sitter service to stay with them, or using our staff around the clock. And that only happens when we don't have anywhere else that will take the child. But it's, I cannot leave them on the street. And so I know it's unpopular, but I think that we all have to talk about it as a state to be able to fix it. We started with 21 kids in the hotels in August of 2024. We saw that number escalate to a high water mark of 47 back in the summer. And then we've made some really big pushes internally. These are often older teens. They have a lot of behavior problems. They're disrupting. I do think that the trauma center with Canopy Children's Services will help. But we've also pushed to find extended family members in other parts of the state that had been refused for reasons when the child was younger. But, now that the child's almost 18 and has better protective capacities, if we can make that setting work with some services or by working through another state, we've been able to get more kids back with family that way. And we're down to 22 kids in hotels today. It's not great, but it is a lot better than the 47 mark. That one gave me a heart attack every night.
Yeah. These are, great reductions, and I know y'all worked really hard at it. It seems to me that there's always going to be some type of need for this very temporary, short-term housing. And have we looked at, I know there's been various things that we've talked about and different things like that. Do we see to get these children out of hotels, do we need to invest in a facility that we know is going to be short-term, that's going to be staffed differently? Do we need to invest in that? I know we've talked about various different things to do this.
Right.
What's your opinion on this?
I think it's going to take a multi-pronged approach, but yes, that could give some relief. And I'll give you an example of, we've worked with Methodist Children's Village, Sunny, we've used a lot of places that have suitable either housing or apartments. Those stay full. But we've recently partnered with, I think it's called the Goodness Project, that purchased the old RTS campus over in Clinton, and they have a number of dorms. We have jointly worked with them to set up more of a community there. It's brand new. We moved 3 kids 2 weeks ago, and 3 more kids. We're moving 3 in at a time. Getting, it's a little dicey. Getting these kids together can also cause additional problems, but and then so I think that some of those situations are better than a hotel. We have control over ingress and egress. We had a joint, like, mandatory training for anyone who's going to be on contract sitting there. And we are bringing in tutors. So we have a little more control over that environment. We can feed them meals, hot meals better. So there's some promise there. I do think we've either got to have access to statewide juvenile detention beds, or more of a diversion program, or both, because a lot of kids are coming straight into my custody out of juvenile delinquency court. And, it's too hard to get them into other facilities that are equipped for them and built for them. And so the easiest thing to do is put that child in CPS's custody and have a social worker pick them up in their car and leave with them. And then we magic something up. So I think access to more appropriate rehabilitative juvenile delinquency beds that are state-owned, because the county-owned system, everybody's sort of punting. They don't want the bad kids in their local detention center. And, the kids that I'm working the hardest on, that we spend the most of our time and energy and resources on, they're well known. I mean, they're on a list all over the state.
Okay. Additional questions?
So you're asking about the juvenile delinquency. Now, haven't we gone down this path before, and we've had some trouble keeping a facility open, and then now we're at a point where we have a big push from an agency to kind of close that all the way down, and now you're saying that we need to be investing and doing what we can to bring it back around in a good shape. So I find a conflict here, and I really want to know what's going on.
Which part?
You're asking for the facility, you're asking for the area. I mean, I feel like that we've got your agency that's over there saying we need to be doing more to make that more accessible, to bring it back up to speed, provide the access. And then we have some other dialect out there that's saying, I want to get rid of it altogether.
Get rid of it all. Is that what you said? Get
Yeah.
rid of it altogether?
Get rid of it. So
I don't like locking a kid up. I don't believe it is the right thing to do for most kids. But we have kids right now that have been passed around in and out of the juvenile detention system and the dependency side. And I don't believe that every kid can be managed, or every adult, without a secure facility that can provide that stable environment and some consistency in how they're treated, and work with their family or find the place that they're going to go, get them in a workforce program so that they have some kind of goal that they're working towards. And that's really what I push the Canopy. It's coming from a not a delinquency side, but still having that full continuum of care, where we got a family that if that child doesn't have any family whatsoever, let's find a foster family that will attach to them and get them a vocation or a GED and have them on a path towards something. Because otherwise, you know, we can throw all the therapy we want at them. If they have no hope of doing something better when they get out of the hospital, then they're not going to get better. So I don't believe beds are the solution, and I would prefer that the agency really not get into owning beds. It's not a good look. And we're not very well equipped to manage facilities. That's not what we do. But I do think that there is opportunity to bring in outside contractors who are interested in opening, I would call more modern facilities here in Mississippi on the delinquency side, and also on the treatment and long-term care side, that are really equipped to handle kids who they've been through the acute care system. We put them on about 1,000 kinds of meds, and they've been discharged over and over. And the facility, you know, each facility adds a new med, and it's not making kids better.
Thank you. Commissioner, I'm glad you're here today. Thank you.
Thank
I want to preface my comments by sharing how much I appreciate you and your executive staff. There have been many times, for the record, that your staff, they're here in the room. They have called me 7, 8, 9 o'clock at night. You have returned my phone calls on Saturdays and Sundays. Perfect response from the executive team. And you've always been helpful, and I've always appreciated not just your response, but the outcomes when I've called and brought very specific issues to your attention. You've been great. But I do want to say a couple of comments. For as much as I think about and respect your executive team, I don't necessarily feel that in what I will call your middle management or your regional teams, at least in the area that I represent. I think you might agree with that.
I know just in your area. Yes.
They have made some very poor decisions. There doesn't seem to be some uniformed, doesn't seem to be a lot of uniformity up there about their standards and the way they operate. It's more like, hey, I'm going to do this today, and they feel like they have the authority to do that. So I'm frustrated with it. I also want to speak. You said, I appreciate you making a few comments about Lee County and Northeast Mississippi, but I think we have some wonderful vendors in that area who are really making differences in people's lives, but they're just not qualified vendors with your organization because some of your team members won't qualify them because maybe they're faith-based or for whatever the reason. I'll give you some great examples. Safe Inc. They take battered women and young children in immediately. They're doing fantastic work. They're serving about an 8-county area, but I bet they're not a qualified vendor for you, but they have housing available and staff on hand all the time. Transformation Home, run by David Ball. Again, he can take up to 80 to 100 women. He has Transformation Ranch for men, Transformation Home. They're just not qualified with your organization, but they're doing real work, and they have beds that are available. The United Pentecostal operate the largest orphanage in the state of Mississippi in Tupelo. They have a school there. They have dormitories. They can help, but they're not qualified. They're not a qualified vendor. You see where I'm leading with this. There are organizations who are in a position to help, but we can't get them qualified. So I want to encourage you to reach out to some of those individuals, to reach out to some of those individuals. I also want to share that I asked earlier Christina Dent to give her own experience, and I thought she answered in a very professional way. But the families, and I realize the amount of children that you guys deal with, that I only hear about the problems.
Mhm.
I'm not hearing the success stories. When families contact me, they're contacting me as a last resort. So I frame it that way. But I've got families that will not be part of the foster care parenting system anymore, because these are, as you know some of the cases I'm talking about. These are well-to-do, upper middle-class families, prominent families, and it's just a hassle. 12 months to get in qualified when they have 5 children in the home already, birth children. They just want to take someone else. Other problems, but I've got these two. I'm not going to take up the committee's time with this, but I've got 2 particular families I would like for you to publicly commit to me. I would like for some of your executive team to sit down and interview them and use them as case studies of where improvements can be made. And then finally, this is something that I know other senators, and I'm the only one here on this committee who's not a learned attorney. So, but I do see and hear about lots of families that are, relationships are difficult, but I hear regularly about families that are going through divorces and separation, and one parent is utilizing your system falsely to attack another parent. I know you see it too. Are we prosecuting any of these malicious false claims when we find out it's maliciously false? Are we prosecuting? Are we turning any of those over to the Attorney General? Are we turning any of those over to the Attorney General or to the courts of jurisdiction and prosecuting some of these individuals?
I'd like to see some clarification in that statute so that that is something we can pursue. Yes, blatant abuse of the hotline is the norm in Mississippi. From up in your neck of the
It is.
woods, it is done for sport, and it is it conscripts my resources. And I've said it over and over. My job is to find the kid in the cage in the closet. And yet
Yeah.
I'm running all over the state, chasing down any and everything. And that's partially because I have to go investigate everything each court thinks I should investigate. So there's no consistency with, right now with the statute, how we are able to even triage, who gets investigated. As to the unlicensed facilities, you and I've talked about this a number of times. And I certainly am open to trying to license some of those facilities, but many refuse to be licensed. And, we have a bad enough time making sure our kids are safe in foster care in Mississippi. When I don't have a license, I have zero leverage to ensure that what happens inside that facility behind closed doors, and trust me, it's not a magic cure to have a license. But the 22-year-old lawsuit we're in, Olivia Y, is all about how children are treated in custody and whether or not they're kept safe by the state of Mississippi once we take them out of their home because of their lack of safety there. And so I am very reluctant to talk about expanding and broadening the very little regulatory guidelines we have now for licensure. Now, what I will tell you is we know already we need to do a better job of customer service with those providers.
Thank you
And
for
be
being
more
honest.
And that's part of what I've made this whole leadership shift for. And it's part of getting kids out of hotels and bringing them back home. It's all complicated, but I assure you that for what is in my control, I'll go and meet with them myself. I would like to hear more about the personal employee stories. I do know that there are, We have an internal investigation unit for that particular purpose. And I don't tolerate my staff abusing their authority. But I do know that back to this, having lawyers in the court and having a uniform court, the courts aren't serving process on parents. They're sending my staff and saying, bring them back in. Well, do you know how my staff can do that? If you don't come with me to court, I'll be taking your kids. So no matter how you say that, that's not the message we should be delivering.
And I understand that. And Commissioner, this is not, I appreciate you, like, as I preface, appreciate your staff and the way y'all have always responded. But this is the appropriate place for us to talk about the shortfalls. I will tell you, I will share with you that a lot of the nonprofits don't want to be licensed because it's difficult to become a licensed agent. These nonprofits, they're operating on razor-thin budgets by the charity and the graciousness of people that support these organizations. And I would like us to set some time aside for you to come into the area I represent, and let's sit down and look at some of these facilities just one day, and then also meet with some families. But we've got a lot of work to do. My hand is out to you as an ally to see what we can do for the betterment of the children of this state and ultimately for our families. And I yield.
Thank you, sir. And can I add one thing on the licensure situation in Mississippi? As you're looking at systemic ways to impact better services and care for children and families in Mississippi, our licensure system in the state is broken. Some of the beds that I have to put children in are licensed at Department of Mental Health. Some are licensed at Department of Health. It's all just split across the state, and there's no accountability. So Dr. Edney, Executive Director Bailey and I have sat and talked. We got to do something to streamline the licensure process so that it is predictable, surmountable, but also holds people accountable when they don't treat our kids like they should.
Commissioner Sanders, it was actually your idea that said that we needed to have the executive agency directors actually play Go Fish, I think was your exact thing.
Go Fish, yeah.
And actually streamline a lot of the processes so that the right agency is providing the licensure and then the oversight of that. I assume you would be supportive of the Senate passed legislation last year that would have really created a entity for y'all to do that and make formal legislative changes that y'all would suggest once again.
100%. Yes.
Okay. Thank you so much. We appreciate the dramatic changes that have happened in CPS over the last few years and your leadership in doing that. So, and we appreciate the openness you've worked with us too. Thank you.
Well, it's all too slow for me, but I appreciate the passion that all of you bring to the table. Thank you.
Madam Chair, Senators, thank you so much for allowing us to have this opportunity to visit with you. We do have some updates and that we would like to share with you at this time. There are two updates we'd like to share about things that have happened since the legislative session. And then we have provided copies of President Trump's recent executive order dated November 13th that I think speaks to a lot of the topics that we've been talking about today. It's focused on fostering the future for American children and families. And then our office has been working with numerous consultants and third parties to conduct independent systems assessments of the component parts of youth court, child welfare, and juvenile justice, and to work toward developing a multi-year strategic plan for youth court. And we'd like to share that with you, as well as the recommendations. There are 12 of them coming from those experts. And you have those 12 recommendations as a handout as well. So the first of two updates from the legislative session that we wanted to mention is that there was a mandate that the Administrative Office of Courts establish standardized intake procedures for youth courts, and that we provide annual training to intake officers on that statewide uniform protocol. And we have done that and are in the process of training those officers now. And I wanted you to see that there was also an appropriation to the Administrative Office of Courts, giving us some funding and some pins to put AOC employees around the state, at least one per Chancery District, to help implement that uniform protocol to ensure that children and families are having a more consistent experience at the outset of what may become a youth court case. And the second update since the legislative session, I'll mention, has not been warmly received by every youth court and their staff. So you may have heard some feedback about that. But in the last legislative session, there was a mandate that the Administrative Office of Courts begin providing an annual report to the legislature on some very specific data about what's going on in our youth courts. And what our office has done is we have asked for that data to be reported monthly so that we could work with courts on an ongoing basis throughout the year to reconcile their data and our data. And we're going to talk about our youth court data system in a minute, but let me just go ahead and say that our system is based on technology from 1999. And so think about what you were using in terms of technology in 1999, a flip phone. So our youth court database and case management system has some limitations, much like a flip phone does. And so we are working with the courts to get accurate data from them on the number of children that have been adjudicated, abused, neglected, or delinquent every month, and trying to reconcile that with our technology so we can ensure that the data that we bring to you at the end of the year is accurate data. There are also some additional developments in the youth court area that I want to mention to you. One is that in the last session, judicial performance was given an attorney position, and there's someone in that position now, and they are charged with auditing, investigating, and monitoring youth courts. And so that process is underway. And then there was also a pilot program in what is now the 10th Chancery District, so that there will no longer be a part-time youth court referee in two of the counties listed, in Marion and Walthall counties. There will be a full-time youth court chancellor who will sit in both of those counties, as well as Lamar and Pearl River. So that's on the horizon. And then I mentioned to you Trump's executive order from November 13th of this year. One of the things I really want to highlight there is that the Trump administration and the federal government are recognizing that improvements need to be made to the child welfare system. They are urgently needed, and that piecemeal approaches would be inadequate. We are looking at some holistic, systemic changes that need to be made. And that's also true for juvenile justice. But the focus of that executive order is really on child welfare. And then that executive order goes on to say, and to really echo what Commissioner Sanders was saying earlier about the importance of data and the technology that can house it, is we need to modernize the child welfare information systems to ensure that we're getting good data and that data is providing us the information we need to keep children safe and to also make sure that the public stays safe. So now I'd like to talk with you some about some ongoing assessments that our office has been doing under our legislative authority to hire consultants. And this really stemmed from, there was a legislative mandate for us to conduct a third-party independent assessment of youth court technology a couple of years ago. And that has now been done. But we wanted to bring all the information to the table, not just an assessment of technology, but an assessment of the other component parts of youth court, child welfare, and juvenile justice. And so we've got the American Bar Association doing an independent assessment of the child welfare system. The Council of State Governments Justice Center is doing an assessment of our juvenile justice system. Georgetown University is doing an assessment of crossover youth, children who were involved in both delinquency and protection cases in youth court, in addition to that technology audit, so that we could bring all the information to the table, to the legislature, so you could make decisions about how best to improve this system. We do need new technology, to be clear about that. We absolutely need it, but these systems need more than just data systems. Also, we have contracted with some outside consultants who are expert at learning or teaching us how to maximize federal funding streams to help pay for some of these things, to help us with project management. These are some really big projects that involve multiple agencies, multiple state plans, multiple funding streams. And it's really important that we braid all these things together and that we sequence them in the right order. We don't want to build technology to do something that a year from now we decide we don't want to do anymore. So to make sure that we're doing it in the right way and that we're looking at a multi-year plan about what needs to be done in youth court, not just what are we talking about this year or this session, but where do we want to be in 5 years? And that includes a lot of stakeholders, Child Welfare Agency, Department of Human Services, Division of Youth Services that handles delinquency, the State Public Defender's Office that handles youth defense and parent representation, not to mention education, mental health, Medicaid. So there are a lot of organizations that are sitting at this round table and all of us trying to figure this out. So I also want to mention that since February, representatives from those groups have been locking in person 1 day a month, in what we're calling Core 4, but as a nickname. But we have been sitting down and trying to figure out answers to problems. We can all spot a lot of the issues. Trying to figure out how to solve them and how to pay for them is a bit more challenging. But I really want to commend the leadership of these agencies for taking that kind of time, for giving up 1 day in person every month. In addition to the agencies, we have 5 youth court judges, some of whom are driving from the farthest ends of the state to come and participate and be part of that conversation. And then we have our consultants available virtually, and they are guiding these conversations and helping us understand what other states have done, what has worked, what didn't work, why that may or may not work in Mississippi. One of the advantages of being a little slow out of the gate on some of these changes is that we can learn from the mistakes that others have made. So now on to the recommendations that we have gotten from these 12 experts. I was asked in a prior conversation to identify any instances where Mississippi is unlike other states, where we're an outlier, where we do it differently than other states. And initially, when we came up with this list of 12, I was asked, well, how many of these represent outliers? And I was like, all 12, all 12. So if you will, just bear with us. We have some opportunities for improvement, but the good news is we're developing a plan to get there. So these are the 12 recommendations. Again, you have them on a handout, but so that you can see them, and they span a full spectrum. I'm going to try to address them all briefly, but I'm happy to follow up in more detail with anybody who would like to talk about any of these subjects in more detail. I think it's going to take some seismic shifts for us to move the needle in some of these areas, because these systems, they're dated, they're old. We've been Frankensteining this together for a really long time. And much like, I probably shouldn't say this, but much like the water system in Jackson, we're springing some leaks, the pipes don't fit. I mean, we've got some real problems. So there are going to be some pretty significant changes that I think are going to have to be made for us to move forward. And I understand there's a price tag attached to it. But one of the things I'd ask for you to keep in mind as we have this conversation is the price tag we're already paying, because we're not fixing the system. So we're paying penalties right now, whether that's the ongoing Olivia Y litigation or because we're spending money in ways that is really expensive. We're keeping children in state care longer than necessary. We're paying those expenses. We're detaining more children than are necessary to protect public safety. Those are expensive choices. And so one of the things I'm hoping we can do is make better investments rather than pay the penalties. I'm somewhat reluctant to use a sports analogy, one, because I don't know much about sports, but also because I don't want it to sound like we're downplaying the importance of the things that we're talking about here. But I do think the analogy is important for a couple of reasons. In Mississippi, we're not covering the field. We've got huge gaps. We don't have enough in terms of prevention services. We don't have enough in terms of diversion programming, which means we are opting for the lengthier, more costly alternatives. And we are also facing an opposing team, so to speak, of some really tough players. Poverty, substance abuse, lack of services or supports, mental illness, intellectual disability, peer pressure, neighborhood conditions, generational trauma, and cultural differences. We're not going to be able to win this game until we cover the field. We have all the players. They're full-time. It's their job to practice and play this game. And so as we go through the 12 recommendations, we may come back to this baseball analogy a few more times. But you heard Commissioner Sanders say if there's one thing that the legislature could do that would have the greatest impact on changing the lives of our most vulnerable children and families in Mississippi, it would be moving to a full-time youth court system. And to be clear, I do not mean this as a criticism of any judge, part-time or full-time, anywhere. But the responsibilities put on a youth court judge are so overwhelming, and the idea that you would have another full-time job and try to do that as well, it makes it very difficult for them to address the needs of the children and families. Same with staff. When the Youth Court Commission reported about this time last year, October 2nd, their recommendation was to move to a full-time system, full-time judges, dedicated trained staff, full-time. The governor has included in his executive budget recommendations for the last 3 years, the recommendation that the state fund full-time youth courts, full-time dedicated youth court staff. So these recommendations are consistent with that. I would also mention to you that NCJ-FCJ, which is the National Youth Court Judges Organization, strongly recommends one judge, one family. One of the things that the consultants said to us is it's very interesting that Mississippi is an outlier in this sense. You have the most court involvement pre-petition before a case is formally filed than any state in the country or U.S. territory. And that really grabbed me. Guam and Puerto Rico have figured this out, and we have not. We have more judicial involvement before a case is initiated than any other state or U.S. territory. Yet 2/3 of our youth court judges are part-time. It's hard to reconcile that. Going to a full-time system offers us so many benefits. It promotes public safety. It will produce more positive outcomes for children and families. When you have a full-time court system, people can come to practice. They can get trained. They can have professional development. It'll also create capacity within this system for our judges to become judicial leaders. And our full-time judges have done that. And that's not to say referees haven't. I just mean that a referee's time is limited. It's the nature of the beast. They have another full-time job. But this will also ensure that we can meet statutory timeframes, both state and federal. In the youth court system, there are many things that have to be done within 24 hours, 48 hours, within 30 days, every 180 days, once a year. It's very different to meet those kinds of requirements when you don't have a full-time court. Last year, when the Youth Court Commission came to report to you, the data at that time was 38 of our 82 counties did not have staff. No staff. 38 counties of 82 were not paying any support staff for youth court. And we assume if they weren't paying them, they didn't have them. So that has affected a lot of things. That tends to mean that we're keeping children in these systems longer than necessary, that the data that's being put in the system is not being entered timely or accurately, which makes it harder for us to make data-driven decisions. There's just a lot of challenges there. And again, not pointing fingers at anybody. I feel like everybody that works in the system, you have a calling to do this work. It is incredibly challenging and emotionally draining. And I think everybody that works in the system, social workers, judges, court staff, are turning themselves inside out, trying to, as Commissioner Sanders said, magic up services and solutions that don't exist. So it's in no way intended as a criticism. But systematically, structurally, it's very hard. We would not go into a game with half a team, the field wide open, and think that we're going to be successful with this when we can't even get everybody together for a practice. That's not realistic. So here's what youth court currently looks like. We have 24 county courts that sit as a youth court, 4 of which handle youth court full-time or exclusively. Then we have a chancellor who elects to sit as a youth court in 2 counties. And in 56, we have part-time referees. One of the other recommendations is that we move to a uniform intake policy and have those protocols. And that's really what our office has been working on since August 1. And we have that policy now, or in the process of training our AOC intake officers to make sure that we have consistency. What has been said about youth court is that we have 82 versions of it. And you will hear the term geographic justice. The experience that a child or family has can vary widely depending on their zip code. So we really want to find ways to ensure that there's more consistency in how cases are handled around the state. To give you an idea of what those intake officers that you graciously gave us, thank you, have been busy doing since August is they're going in and trying to clean up the data. So when we come back to you with an annual report, you've got data that has integrity and that we can make decisions based on. So July 2025, we had over 200,000 open youth court cases. Today, we have 91,000 open cases. What has happened in a few months with resources and training, what we've been able to do is administratively close, and I want to emphasize the administrative part of that. These cases were not heard. They should not have been showing as active cases, and it's not anybody's fault. We have flip phone technology, right? And we have 38 counties with no staff. But what we've been able to go in and do is remove the cases that we don't need to be focusing time and attention on, because in systems this big, we're never going to be able to control the volume, right? I mean, what we want to do is to be able to focus resources on the children that need it most. We want to make sure that the Child Welfare Agency is finding the children locked in closets. We want to make sure the children that are being detained are the ones that threaten public safety. But if we're detaining everybody, if we're investigating and taking everybody into custody, we lose sight of those things. So we really want to move to a system where we have eyes on where is a child physically, where are they in terms of the legal systems and processes, how many days into the next permanency hearing? Are we on top of that? Do we have that scheduled? Are we making that happen? So the good work that the AOC intake officers have done in a short amount of time, I think is really impressive. We're going to keep working really hard so that we can make sure we have that clean data. And then the third recommendation from the consultants is that we have high quality, independent representation. And those are two important qualifiers. High quality, meaning that they have specialized training to do those jobs. Independent, meaning that they are in a position to be an advocate for that child or that parent or that agency. Those are requirements for us to be able to draw down that about 25% of in federal funding that Commissioner Sanders mentioned earlier. And centralizing that legal representation becomes really important. And one of the things that I'm glad Jennifer Morgan was sitting next to me and she whispered in my ear, a kind reminder, just as Commissioner Sanders was saying, having more agency attorneys in the classroom allows law. This is an inherently legal process. You need lawyers to shepherd social workers through this process. But we also need legal representation for parents. And the more lawyers we have representing parents, the more unifications we're likely to see, the less time those children are likely to spend, unnecessary time they're likely to spend in state care. So, and you think about when the average cost of having a child in state care is about $44,000 a year. When Commissioner Sanders was talking about if we shave off 1 month, those lawyers pay for themselves. It's cost neutral, and it may even be a cost savings. But right now, we've got a lot of children sitting in the system that don't need to be. The idea of being able to at least partially fund some of this with federal funding, to me, is encouraging. And I wanted to give you some ideas about what other states are doing. It's important to note that in 2018, there was a clarification from the Children's Bureau, from the federal government, that said Title IV legal, which is the funding source we're referring to, it's always been available for agency attorneys and for children's attorneys. But in 2018, they clarified and said it's also available for parent attorneys. And so back to that baseball analogy, we got to cover the field. We really got to cover the field. If we do that, we're going to get a lot better outcomes for children, and we're going to save the state a lot of money. But so in 2018, when that new guidance came down, states kind of woke up and said, now this is starting to look like enough money. We need to figure this out. And the first 5 years after that guidance came out, Oklahoma drew down 20 million, Louisiana 5.5 million, Tennessee 4.4 million, and Arkansas 3 million. We want to be positioned to do the same thing here in Mississippi. All right, and then agency-directed pre-petition assessment, lots of words. Really what we're saying here is circling about to what we were talking about earlier. We have the umpires involved before the game starts. We have more court involvement pre-petition than any state or U.S. territory. What we want to do is set judges up so that they can do an impartial review and make independent decisions. Call balls and strikes. That's an oversimplification. The work they do is far more complex, especially in this world. But what other states have done is they are relying on the child welfare agency to make the determinations, provide services, and to determine when and if court involvement is appropriate. Same thing on the delinquency side. That's what diversion is. So you don't send every child with a sore throat to the emergency room, right? We're only going to send the sickest children to the emergency room. The others we're going to handle in these outpatient clinics. That's probably a bad analogy, but I'm trying to get us there. For a little reassurance, this is the model that we see in other states around us: Alabama, Arkansas, Florida, Georgia, Louisiana, North Carolina, Oklahoma, South Carolina, Tennessee, Texas. What we're talking about is not radical. What we do is considered radical. And so it puts such a burden on the court system that it's hard for them to move cases along because they are involved so heavily pre-petition. Commissioner Sanders has already spoken to the need for the agency to have attorneys. The consultants agree. This is the national trend over the last 20 years. This is a map showing you that the majority of states have moved to or in the process of moving to agency representation. So a prosecutor would not file the petition in a child welfare case. The child welfare agency, CPS, would file the petition, provided they have lawyers. They have the most interest and making sure that that child moves through the system as efficiently as possible and as safely as possible. But don't worry, we still need prosecutors. They would be handling the delinquency docket. And based on a recommendation we'll see in a minute, truancy. Statewide diversion. This is something that Executive Director Bob Anderson has been talking about in terms of the Division of Youth Services at the Department of Human Services for a long time. Diversion is a lot less expensive than detaining every child. So this is consistent with what other states are doing, just to give you some ideas. Florida's spending $40 million annually on diversion. Oklahoma's spending $37 million. Utah's spending $9 million. There are state investments in diversion programming because it reduces the number of children that come into state care. It provides better outcomes. The more system involvement these children have, the worse the outcomes get. So we're paying one way or the other. But if we move upstream, we're much more likely to get better results. Just to give you an idea of what alternatives to detention and incarceration cost, in Mississippi, we're detaining so many more children than necessary by comparison to other states. Here, we're just showing you Kansas, Kentucky, and Texas, as well as nationally. And you'll see that we are detaining far more children than other states, and we're incarcerating far more children than other states. And that is the most expensive alternative, and it's the most costly alternative. And also, just to give you some idea of what it costs, the average cost of having a child detained at Oakley right now is $160,000 a year. The average cost for evidence-based community programming is $18,000. For diversion programming, it's $10,000. These are better alternatives in terms of cost and outcomes. Just for comparison, if the state were to pay for these children to go to college instead, and we know that's expensive. I got one in college right now. She's about to break me. But Mississippi State, Ole Miss, look at their tuition by comparison. Look what it's costing us to detain a child at Oakley. Please understand, I know there's some children that for their own safety as well as the public safety need to be detained, but we don't need to leapfrog there unless we have to. That's really a last alternative. So the research is clear. Diversion is the most cost-effective public safety strategy for low risk, and we're going to get better results with that. The more touches that children have on the system, the worse the outcomes. So here's the real takeaway message on that. Mississippi is spending millions of dollars on unnecessary court and attorney costs rather than diverting youth who are not a public safety risk. Detain the ones that are a public safety risk, divert the rest. Now, the seventh recommendation is that youth courts become the only option for truancy. Right now, we have 3 courts that handle truancy, and we know chronic absentee is a big issue in Mississippi, particularly since the pandemic. Right now, we've got Justice Court, Municipal Court, and Youth Court handling truancy to different degrees in different counties. In some counties, nobody's doing it. In some, it's 1 of 3 or 2 of 3. But we really want a more consistent approach and to add diversion to this programming as well initially. So there's a way, I think, for us to do this. This just gives you an idea right now of what it's looking like across the state. We had one school attendance officer report that there's 1 county that's not handling truancy. We had 6 youth court referees report that they don't handle truancy. I can't reconcile the differences. I'm just reporting what the surveys say. And then we have 19 courts that haven't received a truancy referral this year. So something's not working. I think there's some opportunity here. We really want to work with the Department of Education and youth courts to make sure that we have a more consistent approach to how this is handled. Truancy is not being handled in a lot of counties, and then it's being handled in the most expensive way in terms of time and money. In a lot of other counties, we're going directly to court. It's like monopoly, right? Instead of, go directly to jail. Do not pass go, do not collect $200. We're going directly to court involvement. We need diversion programming on the school level. If that doesn't work, it goes to the agency level. And if that doesn't work, then it goes to a court. And so that's really what this slide is intended to show you. On the left is what we currently do. We go right from the school to court in the counties where it's being reported. And then what we're proposing is that you have two levels of diversion instead, and the courts are handling the cases that cannot be resolved without court involvement. Expanded and dedicated prevention programs and services. Just like Commissioner Sanders was saying, just like Executive Bob Anderson has said in other forums, we've got to have prevention services on the child welfare side. We've got to have diversion program on the delinquency side. Right now, Mississippi is an outlier because we lack the infrastructure and the dedicated state funding to support those systems. So we pay the penalties instead of investing further upstream. Our ninth recommendation from the consultants is that we address crossover youth. 40% of the children in Mississippi who have youth court involvement have involvement on both sides. They are adjudicated both abused and neglected and delinquent. Right now, those systems function in silos. We've got to have cross-agency and cross-system collaboration. We've got to think strategically about how to maximize funding streams to handle that crossover issue. And the consultants have some ideas about what other systems have done, what other states have done. Know that children that have involvement in the child welfare system are nearly twice as likely to show up on the delinquency side. So the data's there. We also know that the more touches that a child has within these systems, the poorer the outcomes become, both for them as a youth and then for them as an adult. So we really want to try to intervene, to get upstream, to provide services and supports earlier in the hopes of rehabilitating and turning things around rather than ending up with poorer outcomes and the more expensive alternatives. Then number 10, this is where I feel like I should tap dance, but we need modern technology for the youth court system. We are seeking an $8 million appropriation this year to replace the dated My Kids, and that's My Kids spelled with a C, I think just to aggravate me. But to replace that system again, 1999 flip phone technology, it cannot do what we need it to do now. What we want to be able to do is have a youth court case management system and technology that can speak in real time to the fancy program that Commissioner Sanders was talking about, the Child Welfare Agency, this Pathways, which was a $38 million custom build. We want to be able for those systems to share data, only the data that they should be sharing, instantaneously so that we can have data dashboards and we can see on a single screen without having to mine for data. We know where a child is legally, where a child is physically, how many days they are from one hearing and how many days until the next hearing, so that we can track a child's progression through these systems and do everything we can to ensure that they spend as little time in these state systems as possible. But until we have this kind of data, it is incredibly difficult to do. The 11th recommendation is that the state focus on access to justice. We have a confidentiality statute in youth court, which means the courts are closed and the records are sealed. And that limits the ability oftentimes of extended family members and fictive kin, those who were like family members, maybe a Sunday school teacher, a basketball coach, to be in the youth court proceedings. And then also we have attorneys who want to do pro bono service in youth court, but can't figure out how to get in. And so we want to create avenues so that we can try to get more attorneys involved in youth court proceedings. We don't have people lining up to do this work. It doesn't pay well, and it's emotionally very challenging and draining. And then just quickly, I'll highlight for you, Georgia has made some changes to their youth court system to allow that children and families who are involved in youth court can bring family members and their support system into the courtroom. And one of the unintended benefits that they found from opening the courtroom up some is that they had more placement opportunities for those children. And our final recommendation is funding, that the state get earnest and strategic about how to maximize federal funding streams like FFPSA and Title II and Title IV-E. and that we work across agencies to make sure that we are doing everything we can to bring every dollar in to serve these children and families who are so vulnerable. The real takeaways here are full-time courts, modern technology, statewide diversion and prevention services.
Okay, you've presented a lot of information.
I did, I tried really hard.
I'm gonna do y'all have some questions on it?
Any questions?
Senator McCon?
You're gonna let me start off.
I'll let you
Senator
start.
McMahon says I'm not really speaking. And I'm not with you on all this, Vicky. And I've known you since I was in law school. I think you were doing our writing program when I was there.
That's right.
And I have a problem with a lot of this in that I want to know, you tell me all the things that we're doing bad and we need to fix. So show me where we're not meeting these deadlines. Because I know for a fact that the youth court referees that are out there in my area
Yes.
are doing what they're supposed to be doing. But the one thing, the last time I was in youth court representing someone, I had 4 different caseworkers. So why didn't we take our AOC money and put it towards caseworkers? Because that's the most frustrating thing to me is for a caseworker not to be there or have a different one next week when we've got such a good one working through it. And I know, Andrea, I'm not getting on, we've had this discussion right here in this room before, that our biggest problem a lot of times is trying to keep those people employed.
It is.
And we got to pay them because it's not easy. Ask any social worker, you can't adopt every kid that you go across that you want to.
That's right.
So I have a question about that. But before I even get there,
Okay.
why did we take all of the equipment, since we're wanting to go modernizing, why did we take equipment away from our counties earlier and leave them on the hook having to rebuy everything? Let's start with that one.
Sure. First, let me speak to the equipment recall. So equipment was distributed during the pandemic to ensure that we could have virtual hearings. That equipment stayed out with the counties, but at state expense, maintaining licensing, updating, replacing lost mouses and speakers and whatever. Doesn't sound like a lot of money, but we were spending over $300,000 a year on equipment. And so we want to shift that funding to improvements for youth court that go beyond just providing equipment.
How did we equip our new officers?
I'm sorry?
How did we equip our new officers?
The new AOC intake officers?
Yes,
With that recycled equipment.
that's what I thought.
Yeah.
So now we took it away from our officers who were doing the work to put it into AOC workers that you're bringing in.
Well, some of it. I mean, we only have 20 AOC intake officers around the state. So also some of that equipment was purchased with federal funding that has some requirements attached to it that we're not able to meet. And so rather than find ourselves subject to repaying the federal government, we have recalled that equipment. We have done a needs assessment based on what each county has. And we will be, and beginning in January, reassigning and redistributing that equipment based on need. Some counties do need scanners. Some need printers. Some had 14 scanners sitting in boxes that had never been opened. So we're trying to redistribute them to those who need them most. And I understand that during the pandemic, everybody was scrambling. So I can only imagine what the initial distribution process looked like. But we want to make sure that it is as equitable as possible. Some counties can afford their own equipment. Some can't. So trying to make sure that that equipment is going to the counties that need it most. And that we have met whatever grant requirements if federal funding was used to purchase the equipment. So that we don't have to pay the federal government money that our office does not have. Now I forgot your first question.
So let's get back to the AOC workers.
Yes.
So these people that were sent in here and so now I have a clear definition of what they were sent in there for. AOC to implement your protocols. They're not there for intakes. They're not even here for
No,
any
they
of that.
are. These are intake protocols. And remember too, that 38 counties were reporting they had no staff. So we are prioritizing providing support to those counties first and then overflow for some other counties. I mean, some counties have some staff, just not enough staff. So we're trying to be the reserves. Some other counties had challenges where if somebody was out on maternity leave, There's nobody to input data for months, that sort of thing. So we're trying to go and provide whatever kind of supports we can, but doing it again based on need, where the need is the greatest.
Well, and that's where I'm getting at with it,
Okay.
is that I don't feel like we did that.
Okay.
I don't feel like that we put those people where they need to be, because that was my first question, is my biggest problem in youth court has been that I don't have the caseworkers. I finished an adoption, actually, I did an order a little while ago on it for the purpose of going around CPS. We went
Right.
through and got everybody else involved because we didn't want to have 900 days worth of people that were waiting on. And I think that
Mhm.
we can do that. We can do more of that.
Yeah.
In which we can actually get the job done and get the kid adopted where they're supposed to be, instead of sitting out there when we go through 3 or 4 caseworkers and they all have to get caught back up. So
Right.
my question there was, why are we not out there paying them what they need to be to keep them in the system to do the jobs that we need them out there? We're so focused on the outside and all the semantics of the situation, we're forgetting our number one role,
Well,
and that's what's in the best interest of the kid.
and I apologize. I didn't mean to speak over.
No,
you.
you're fine.
Reverting back to the baseball analogy, we got to cover the field. We do need more social workers. They do need to be paid more. But we also need people tracking data and helping us. They serve as a check and a balance in this system that I think is really important. There's no way to know whether a child is sitting longer in one of these systems than is absolutely necessary unless we know if the agency is late with the investigation report or the court is late reviewing the investigation report. Right now, that sounds very simple. In our current system, flip phone technology from 1999, you have to mine through about a dozen screens to be able to figure that out.
And I can understand that. I can understand that we need to get some data in there
Mhm.
in a situation. But I don't think we need to get lost in the fact that data is great. But at the end of the day, we've got to get those kids where they need to be.
Absolutely.
We got to get the one out of the closet y'all keep talking about over there. So that's where the CPS and the workers come into play.
Yes.
My other question here, though, is now we're moving into throughout your system, you're talking about it, and you've created a whole lot of new jobs for lawyers.
Yes, but we
At
need
least
more
you-
lawyers.
At least 56 of them, because you're saying to get away from the part-time ones here. And
Well, I
we're-
don't think that's the understanding. I don't think that there would be 82 full-time youth court judges. I don't
Well,
know that the caseloads would warrant that, but
If you dropped in one chancery in our new chancery district, you'd put one youth court judge full-time for 7 counties, and that is an impossibility, period. You cannot go across 7.
well, I think it depends too on what we're asking our judges, our umpires to do. If we're asking them to be involved pre-petition, I think you're right. If we're going to move to the model that nearly all other states have, I think we're the only one that has differed. And having significant judicial involvement pre-petition, I think you're right. I mean, the numbers on caseloads drop precipitously if you don't have judges involved until a petition's filed.
I agree. And I think that's one question, the last question I had on that was, if you're moving away from taking responsibilities from, or taking away the responsibilities from part of the judges,
Mhm.
then why are we looking at going full-time if you're taking away the duties you're looking at?
Well, I think it's just finding I think we've got to decide where everybody's lane is. And right now, the lanes vary depending on the county. And so the way child welfare operates or the way juvenile justice operates is literally different all over the state. And I don't think that produces the best outcomes for children. That doesn't mean that in some areas it's not fantastic. Please understand what I'm saying, but there are also some areas where it's less than fantastic. And I think we've got to track data to try to figure that out, where things are getting stuck. And to have data systems that will allow us to better understand why they're getting stuck so we can get them unstuck. But I think it's a combination of things. But I think we're spending an inordinate amount of money right now on the most expensive, lengthiest outcomes. And if we move upstream, we have an opportunity, I think, to spend money differently, not necessarily more money, but in different ways and get better outcomes.
All right, Senator England, and then Senator Wiggins, I'll get you.
Thank you, Madam Chair, and thank you, Vicky.
Yeah.
I have a question, but I also kind of have I guess, a statement about this, because I see all of this information and it's very, very helpful, every bit of it. But this is a big change, and I
It's
know
big.
when I sat on the task force that was to look at the youth court system, some of the changes sit well and some don't, because we're making changes. And I think that's the case. And I know that when I see that you tell us that we're doing our pre-filing judicial involvement as part of our hang-up, and I hear that, well, I say, okay, well, that's one step that we can take to get towards a better system. The full-time dedicated staff was, I think, something that everybody mentioned was necessary when we talked about it, because even the data that would be important, we don't have anybody that can do that. And I don't practice youth court. I admire everybody that does. And when I sat in that room, I understood. I thought maybe I was able to offer something just by not being part of the system, right, and seeing it. And I see where I practice in workers' comp, we have a commission here in Mississippi. Alabama uses every civil court to handle their systems, and it's wild that they do that. They're one of only a few states to do it, and they need to make changes, but they're not, because they're hard to make.
Okay.
So I say all of that to say this: of these 12 bullet points that we have, I think if we as the legislature were able to listen to you and to others and look at, which one or two could get us moving in the right direction, because when we see a packet of 12 items and we're thinking, oh my gosh, that bill's going to be, we're going to kill a lot of trees.
Yes.
But I think there's a few that are priorities that we could look at while we're digesting all of this stuff. And I think that the among those first few steps, one would be to make sure we're getting the data input
Yes.
properly,
Yeah.
so that we can come back and look and see what we're doing. Because the ultimate thing that troubles me are the graphs that show. And I know Christina had a few good points. You've had a few good. Everybody has shown where if we fail on the front end, the more problems that end up snowballing to where then we have a child that's incarcerated and it's in our system, and that
Yes.
I think our corrections budget is always like number 4 out of 100 different things. We're spending a lot of money on corrections, whereas if we did something better on the front end, we could save on that. Education could benefit that. So I would like to see maybe, and maybe they are they have been prioritized, the 1 through 12. But just I wonder if maybe you could get with us. I love a one-pager, right?
We can do a one-pager.
Right. With something that says, hey, these that we think are the easy changes that we can make right off the bat, because otherwise we're looking for loopholes, and we're not addressing problems. We're creating more further down the road.
Yeah. And yes, Senator, and to echo that, one of the reasons we asked these different consultants to map this out is we're not exactly sure how to get there, the best way to get there. We're looking at other states, we're running numbers, we're asking them to do projections, we're looking at imperfect data, we're comparing our data with CPS and DYS and trying to read between the tea leaves and figure out why our numbers don't match. It looks a lot like my personal checkbook at home. I cannot reconcile and get the things to match. But we're doing our best to try to discern what's going on there. But this is I think what we're trying to do is agree on where we want to be in 5 years. We don't have every step of this mapped out perfectly between now and then, but we're trying to agree on a destination. And so that's why they were trying to give us a holistic picture. So you understand that as you add something to this player's plate, you're taking something from that player's plate. We're not overwhelming somebody with asking them to do something that we know cannot be done, right? Or to handle caseloads that are not manageable. And none of these things would happen. We can't turn the Titanic, I need a better metaphor, but on a dime. I mean, this is a multi-year actionable plan. So to try to understand what are our initial steps, what's the sequencing, right? What I don't want to do is build technology for something that we realize in 12 months, we don't want court involvement pre-petition. Well, shoot, we just spent about $2 million building that into the system, right? I mean, to be thinking logically about the sequencing, even if we can't do it all now, but we're agreeing on where we want to be in 5 years.
Right. And one thing I feel like I can foreshadow, just being in this building long enough to know, is that once we start building the system, the people that we're paying to be experts at it are then going to become youth court family lawyers, and because they're going to make more money being paid by families, and then we're going to be, because we see it in agencies where they get an engineer right where they need them to be to move the system along, and
Yes.
and then they get offered from a company to come work for them, and that's that's great. It works for them, but I guess once we get a system in place, hopefully we can
Yes.
have it moving. But
Yes.
that's something I want us to be aware of too, that we're going to
Yeah.
have. The next request will be like, well, we loved when we had these guys, but now they're making more money doing the other thing, and we just
Right.
need to be ready for that.
And Senator, I will say the one thing that the consultants all agree on, the bedrock recommendation on which everything else stands is the move to full-time youth courts. And again, that was echoed in the governor's plan for the last 3 years. It was echoed by the Youth Court Commission's report and recommendation last fall. This move to a full-time system, I think, is what allows for all these other things to happen. Just understanding that we got to cover the whole field, at some point. Otherwise, we're not going to have the checks and balances necessary in the system.
All right.
He gave up.
Ava, I will say that,
Me?
Oh,
yes.
there he is.
Oh,
Yeah.
okay. I didn't know that centering was finished. So thank you, Vicky, for your presentation. I just want to say I appreciate the thoroughness and the data-driven look at this. And we'll simply say it's about time that we did this in our youth court system. And I think what you've highlighted and others is once we started looking at this, we found these issues. And as Senator McCon said, it's about the child or the children. And, the whole point is to keep the focus on them. And I do feel like at times when we've been working on this, people want to talk about this, that, and the other, as opposed to about the children. And I think what we've heard here today is that the children, there's a lot of problems in dealing with the children in this system. So I appreciate it. And so I have 2 questions. One,
Make them quick. Make them quick, please.
all right.
Make them easy, Senator. I'm sorry.
Well, you said the more judicial involvement on the front end, Mississippi's the outlier.
Yes.
And then those other states. Can you explain, I guess, what that means? Because even I have a little bit of a hard time understanding what that means.
Yes, I'll be happy to try. So in other states, a judge does not get involved until a petition is filed. They are not involved. They don't review the investigation report. They don't order a prosecutor to file a petition. The prosecutor would make that decision. On the delinquency side, the child welfare agency would make it on the protection side. Once a petition is filed, that is the first information that the judge or the umpire, to go back to our baseball analogy, that's the first information they would have about that case. They would not have been involved in pre-meetings or conversations either with the family or the children or with agency staff about the case until a petition is filed.
Okay, so that means, if I understand it right, that's more like what I would call a traditional court.
That's
where
right.
The judge is, whoever the hearing officer is there calling balls and strikes, essentially, as
That's right.
opposed to directing the social side of this.
That's right. It really focuses on having social workers focusing on their piece of it, and then judges calling balls and strikes.
Okay.
And if you have attorneys, if the field is covered and you've got attorneys, what happens is the court is then only asked, as you know, in other state courts, they're only there to resolve the issues that the parties can't agree on. But when you have parties unrepresented, that no longer works. And so it's one of the reasons in youth court, we don't see agreed orders, because we don't have all the parties represented. So we have a lot of hearings that probably don't need to be had if we had attorneys involved and we were submitting proposed agreed orders and moving things along.
And I do think that's an important point, that if in the regular practice of law, no matter where you are, attorneys actually through agreed orders make things go forward.
Absolutely.
And move things along. So, okay.
Absolutely.
And then my other question was, when you said that people, it wasn't received well, or at least not very well, what were you talking about?
That was our request that youth courts provide those mandatory reporting requirements from this last session, that they provide those to our office on a monthly basis so that we could all work together to ensure that we have integrity before we submit the annual report. And to try to quickly explain that, our technology, 1999 flip phone, doesn't know the difference in an adjudication that was held, one that was set, or one that was rescheduled. So if we run the report on our flip phone, we get the wrong number of adjudications instead of an accurate number of children who were adjudicated, abused, neglected, or delinquent. And so we're trying to work through those issues, identify what's wrong with this mousetrap that we're currently using, and then hopefully we can build a better one so that eventually these kind of reports can be automated and we still have data integrity.
So, excuse me, so where you sit from your observation, why was there, I guess, pushback on submitting this information?
I think
Staff.
a lack of staff. Thank you, Madam Chair. But a lack of staff in a lot of courts, in a lot of counties. And I think too that a lot of courts and judges were concerned about the amount of time it took them initially to get that baseline number to work from, which we admit was hard. How many active cases do you have? And then we're trying to take their numbers, compare them to our numbers, and figure out where we are and why there's a disconnect. And I think that we're in the beginning, and this youth court, child welfare, juvenile justice world, we're still in the early stages of focusing on data, of harnessing good data, of having data integrity, of making data-driven decisions. And what I'm hoping is that we will all get in the habit of assessing our data on a regular basis, comparing it to other people's data and having conversations about it. And one of the things we have on the horizon for the next calendar year is to start having monthly Zoom meetings with the agencies and with the courts that's all data focused. Here's what we're seeing in the numbers. Here's what we can't reconcile in the numbers. We're confused about this. What are your thoughts about that? And CPS showed a lot of really fantastic data today, and then comparing that kind of data. The AG's office has fantastic data about what they've been doing in representing the child welfare agency. I'd like for us to get into a regular habit of sitting around the table and talking about our data. And then it may be that your numbers are better than mine, or I didn't consider something that you considered, but so that we're really having those kind of exchanges on an ongoing basis. That's a new concept really in this world.
All right.
Okay,
Thank you.
Okay, thank you.
Thank you for your testimony. I think we all have clearly got the message today that we need a diversion programs. So we need some pilots on some of those programs. So, Doug, thank you. I'm so sorry. You were we are way late in getting to you. So I apologize. We are an hour and 15 minutes later than we were supposed to have him start. So I so appreciate you staying.
I have spoken enough to know you don't stand between your audience and lunch, and I think that probably applies to the end of the day as well. So my remarks will be moderated accordingly, but Chairwoman Boyd and Senators, thank you so much. General Fitch is sorry that she couldn't be here today, but she is very pleased to have the opportunity that you've invited us to talk about the things that we've been doing, and we're going to share. I'm going to preview with you some things that we're going to be bringing to you this next legislative session. And I'd like to introduce Lainey Russell. Lainey is the director of our Children's Justice Division, and she and her attorneys are in the trenches every day. And some of the numbers I'm going to touch on towards the end of my remarks are directly related to Lainey's efforts and to her team's efforts. And so I want to give her all the credit that is due there, because she has just done a phenomenal job, which I'll touch on briefly. And I also want to thank Commissioner Sanders for her
her collaboration with us in the pilot project that we're gonna mention here briefly. But I assumed my role as Deputy Attorney General earlier this year, but I've been with the Attorney General's office since 2012, starting as a line litigator and then becoming Director of Civil Litigation, which I was doing for the last 5 years. So I think it's with that perspective that I can attest to the increased focus and energy that our office has been able to bring in this space related to women, children, and families under General Fitch's leadership. And as she so often says publicly, not only is it a moral imperative to support women, children, and families, but it is in our best interest and as a state, because when our families are strong and healthy, we know so are our communities and so is the state. So as you all know, following the Supreme Court's decision in Dobbs, the Attorney General launched her Empowerment Project, and it's largely around that framework that our office has organized our efforts to support women, children, and families. And the Empowerment Project has 5 pillars: making quality childcare more accessible and affordable, promoting workplace flexibilities, improving child support enforcement, streamlining, improving adoption and foster care systems, which we're going to talk specifically about, supporting pregnant women, mothers, and their children and families with the resources and opportunities to upskill and educate and grow. So everything the office has done in the last 5 years has been really framed around the Empowerment Project. And I'd be remiss without saying how appreciative the Attorney General is of the strong support that the legislature has given the empowerment agenda and has passed dozens of initiatives that we have brought here as part of the Empowerment Project over the last 3 years. In the coming year, we do intend to bring additional proposals to the legislature, including one we've worked on closely with Director Anderson and the Department of Human Services to develop recovery of child support arrearages through casino winnings. And as you all know, in setting up the lottery, the legislature ensured that children would receive priority considerations for lottery winnings. However, that is not currently the case with casino winnings. There are nearly 160,000 children owed child support currently in the state. That approximates to about $1.7 billion. And so, for families, that's the difference between, having a healthy meal or going to bed hungry. So we feel like we brought that last year and working in collaboration with DHS, and we're going to be back with that again this year. But we really feel that that's a very, very powerful initiative. These children deserve our best efforts, and we look forward to working with you on our legislation with Director Anderson and his staff. We're also going to be seeking some minor improvements to the Safe Haven Baby Box law that you all passed in 2023. And since you approved those changes to allow for the Safe Haven boxes in Mississippi, we now have 8 of those life-saving options that have been installed across the state. Several more are in process of being established. And most critically, at least 3 babies have been recovered through the drop boxes. Our experience through the year and working with Director Roussel is that the baby boxes have helped inform legislative changes, but now we can see a few things that we feel like we can streamline that we're going to bring forth during the next session to make sure that, we've talked a lot today about variances between counties and variances between courts, and what we want to achieve with the baby drop box, which we think was your intent when you passed it in 2023, was to make sure that that's process from the moment that baby is placed in that life-saving box to the time CPS takes custody, that there is a very deliberate path for that baby to move through the process and ultimately seek his or her forever home. So we're going to be bringing that to you in the next session. And of course, the MAMA, or Mississippi Access to Maternal Assistance, continues to be a great success. Since the website's launch in October of 23, it's been visited more than 88,000 times by more than 27,000 unique users. We have more than 400 public, private, and faith-based resources and services on it, and we are consistently looking for opportunities to continue to develop those partnerships and add to the database and promote its use to women and families in need. And if you haven't had an opportunity to look at the app, it's really incredible. And like I said, we continue to add to it, and it's been one of our most successful initiatives and drawing in such a huge swath from faith-based organizations. So we're very proud of that, and we want to continue to see that expand and grow. In addition to the legislative initiatives, the Attorney General is focused on criminal work around projects that address the needs of women, children, and families, including aggressive investigation and prosecution of child exploitation and human trafficking. Our Internet Crimes Against Children, ICAC Task Force, continues to see increases in cyber tips throughout the state. In the period from January 1 to December 5, 2024, we received 5,615 tips. During that same time frame this year, we've more than doubled that to 12,105 tips. So that is obviously, it's a sad number, but the fact that we're getting those tips and that's leading us to additional information just in 1 year, that's something that we want to continue to work with all of our partners on, which I'll speak about in just a moment. We have now established cyber labs and forensic experts on the Gulf Coast, in Oxford, and in our Jackson office in order to have the best assistant law enforcement across the state, offering a full-time, cost-efficient manner. We've trained 264 law enforcement officers on ICAC-related issues and an additional 76 on the forensic lab techniques to make sure that this service is available throughout the state, not just in the Attorney General's office. The Attorney General's Human Trafficking Task Force this year alone organized 5 multi-jurisdictional operations, resulting in 112 arrests and recovery of 49 human trafficking victims, including, unfortunately, 2 minors. These operations included 2 that were part of interstate operations, Operation Game Over, which we conducted on the Gulf Coast with the Louisiana AG's office during last year's Super Bowl weekend. That was a very successful operation, again, unfortunately, but Operation Coast to Coast also spanned 50 states involving 150 law enforcement officers nationwide. Finally, in this space, the Attorney General's office organized our first statewide operation, which was called Operation Guardian Force. You'll find the data for that operation on the last page of your packet that I handed out, so I won't repeat those. But this 12-day operation included saturation activities led by our fentanyl strike force, sex offender registry compliance efforts led by our ICAC Task Force, and human trafficking stings led by our Human Trafficking Task Force. So this was the first statewide multi-task force operation. We worked with our local partners. We had federal observers come down when we were in the northeastern part of the state to observe us. They were incredibly impressed with our operations and called it a model that others across the country should pattern after. During that task force, with the assistance of, as I said, 400 officers from 21 federal, state, and local agencies, we executed 24 search warrants, 4 subpoenas, issued 5 misdemeanor citations, and made 72 arrests. And we worked with victim service providers, sexual assault nurses, and human trafficking survivors. We recovered 29 victims in just that operation. And I would say anecdotally, one of the things that were reported to us when we were in the north part of the state, the operation was taking place during the morning at a what you would consider to be a perfectly fine hotel, and there was activity going on in broad daylight on a Wednesday in the middle of the week at 10 o'clock in the morning. So that task force was obviously something we hope to replicate and continue to expand on. Operation Guardian Force was also our first opportunity to utilize the new online platform and mobile app that concerned citizens can utilize to send tips to our task force. In fact, during the operation itself, a tip was received through the Simply report that led to our team to recover a live victim in real time, in progress. The AG's office has also made educating and engaging Mississippi public a high priority since General Fitch took office, rolling out the first phase of the Be the Solution initiative in 2021. Just last month, we brought on our newest team member on board to assist with our child exploitation and human trafficking. Trace E, which is TRACE, is an electronic sniffing dog that can locate even the smallest of electronic storage devices. So when our officers go in to execute a search warrant and the perpetrator may have hid electronic devices, thumb drives, hard drives, whatever it is, this dog is specifically trained to sniff out those devices. It keys in on the glue, I was told, that's used to put together the hard drives and the thumb drives. But she's an amazing dog. She just joined our team a couple weeks ago. Both Simply Report and Tracy are funded through the grant funding procured by the AG's office. And on her second day with us, she was a part of a search warrant execution. She is one of only 3 ESD canines in Mississippi, and agencies across the state are obviously eager to work with us, and we're eager to share our resources statewide. This year, our Special Victims Unit continues to prosecute human trafficking and child exploitation cases. Earlier this year, we successfully prosecuted a case in Hinds County that led to a 48-year sentence to be served day for day without the possibility of parole for 2 counts of human trafficking, 1 count of possession of fentanyl with the intent to transfer. We were grateful to the legislature because it's through those efforts in strengthening Mississippi's human trafficking laws that we are able to enforce these statutes and put these criminals behind bars for lengthy periods of time. In the coming year, we intend to come back and ask you during the 26th legislative session to consider requiring that those convicted of human trafficking register as sex offenders. Alabama, Louisiana, Texas, Tennessee, Florida, Georgia, and Arkansas all require those convicted of human trafficking involving activity to register as sex offenders. Currently, our law only provides that prosecuting sexual servitude of a minor is a registrable offense. So we've got a gap in that law that we're going to be asking you this session to close up. The Attorney General's Bureau of Victim Assistance has placed particular emphasis on addressing domestic violence as well. 3 years ago, we launched 2 new tools for law enforcement, court personnel to use and track incidents of domestic violence, filings of domestic protection orders, DAPOs. In an effort to make utilization familiar and easy, the Mississippi Domestic Violence Registry was built on the same platforms that the law enforcement utilizes for motor vehicle traffic. So it's a very user-friendly platform. The database provides law enforcement with the kind of information that saves lives, innocent bystanders, and officers alike. In fact, we built into the platform nationally recognized lethality assessment protocol, which gives law enforcement officers an understanding of what could lead to an escalated situation and protect them and protect others at the scene. Since January 1, about 5,400 incidents have been logged into our DVR. The Mississippi Protection Registry Order is believed to be the first of its kind in the nation to combine both civil and criminal DAPOs in a single location. The premise, again, is that information of that kind is life-saving. Additionally, working with the Mississippi Access to Justice Commission, our office unveiled a step-by-step online program that can walk an individual through the process seeking and filing a DAPO. We have conducted continuing legal ed trainings aimed at teaching individuals who may engage in pro bono work outside of their traditional areas of practice so they can use this tool as well, so we can expand that pool. Our website includes a full list of brochures and materials we've created and disseminated statewide, and we regularly update them as changes occur. These include the Bill of Rights brochure for victims of sexual assault, resources and reporting. And we certainly invite you, if you have not seen this, we'd be happy to sit down with you one-on-one. If you'd like this material for your constituents, just please reach out to us and we'll be happy to do that. But that is something we try and push out at every opportunity. And finally, I'd like to address something that Commissioner Sanders brought up about our Children's Justice Division, which is a new division that Attorney General created to support child enforcement and representation of the Mississippi Department of Child Protection Services in moving children along the pathway to their forever homes. Commissioner Sanders touched on some of the global statistics about the success of the pilot project. Working with the Department of Human Services this year, first of all, before I get to that, working with DHS, the division has obtained indictments for more than 1.2 million in past child support. Now, collection of that is obviously another story, and we will continue to press hard for that. But we are aggressively, I think that may have come up earlier in the day, we are aggressively pursuing things of that nature, and we will continue to do so. We've added a second investigator to this team to assist in the work necessary for these prosecutions, which we hope will accelerate our work to assist these families. So I think what's most exciting as we're looking at this system as a whole, and it's what I'd like to leave you with, is what we're doing in the foster care space. It's our understanding that CPS currently has 18 counties in the foster care pilot program, and our preliminary data shows that this pilot program can provide what we think is groundbreaking model for moving children through the foster care systems towards their forever homes. While CPS assigned 5 of those 18 counties to the Attorney General's office, Laney's experienced team of attorneys and paralegals have also continued to pursue TPR in the other 64 counties, which are not part of the pilot program. As of today, we have already legally freed 620 children for adoption. That's updated from what's in your packet. Laney updated me on that before I came up here. And that exceeds our total from all of 2024 of 596 children, even while assuming the additional roles in youth and chancery in the 5 pilot county projects. Further, as of that same date last week, the AGO is responsibility for seeking TPRs for 458 children in 240 cases with a plan of adoption. Of those, we have attained trial dates in 167 of those cases for 339 children, and we're working on cases for the other 119 children actively. So back to the data that Commissioner Sanders touched on, but I think it's really important as we leave here tonight to look at the success of the pilot program. And I'm going to just go through real quickly in the 5 counties that the AGO is handling. This means that there is a single attorney from the shelter hearing through the judgment of the TPR. And we think the numbers speak for themselves. So from 2024 to 2025 in the counties assigned to the AGO, we saw an average of a 60% decrease in the time a child spends in his or her custody from his or her custody date to TPR judgment date. And in the materials I've provided to you, we've actually broken each section down more granularly, but just for sake of time, I'm just going to focus on the time from custody to judgment. And you'll see in Jackson County, that number is down 68%. From 551 days to 178 days. Forest County, 477 days in 2024, down to 164 in 2025, which is a 64% decrease. Pearl River County, same thing. We're down 69% from 388 to 119 days. Lowndes County, we're down 41%, 596 days to 351 days. And finally, Scott, which is our 5th county, even while more than doubling the number of cases, the time from custody date to TPR is down from 593 days to 272 days. And that's a 54% decrease. And as Laney reminds me, there's a lot of variables that go into that. And at any given time, there's new cases coming in. But it is our assessment and is her judgment that the continuity of having the same attorney move that case throughout the process again, the numbers speak for themselves. And I just think that it is the one shining path to getting these kids from custody to on their way to their forever adoption homes. Our initial recommendation to CPS for the pilot project had our team of 14 attorneys working in 26 or 30% of the state's 82 counties while continuing our other responsibilities. We continue to believe that we can handle a greater caseload with our current complement of children's justice attorneys and paralegals, and we're prepared to add more to meet the needs of these children. I would note the AGO did not receive any ARPA funding for our part in the pilot project. And while federal funding may be used, the Attorney General did not receive Title IV-E funding for either our work in the pilot or our continuing work on TPRs. There is no question, in our opinion, that children moving along the pathway for their ever home more quickly when we have consistent legal representation, starting at the shelter hearing and continuing through the custody process. And there is federal funding available to the state to expand the Attorney General's work to bring this pilot project to children all across the state. We look forward to continuing our work with CPS and Commissioner Sanders, and most importantly with you, the legislature. You've been very good in our work with this area. This is what we've talked about all day today, and we think these numbers are a real bright spot in what's otherwise a very challenging space. Obviously, this is just a snapshot of what we're doing. We look forward to continuing our work with you in this upcoming legislative session. Director Roussel is obviously very excited about the work that her team's doing. And again, I want to compliment her and make sure you all know that she has just done a phenomenal job, and we continue to more success in 2026.
I'm going to let y'all ask questions first. You're good? Okay. Bryce or Senator Wiggins, do you have questions? What? Senator Wiggins, are you with us still? Okay, I'm gonna ask some real quick questions here. First of all, these are incredibly impressive numbers. And I heard one youth court judge raving about your staff in their courtroom and the difference that it has made. They were putting in a plug for it. So is the main factor like of this that you have an attorney from the very get-go to make the case? Tell me like where you see the real things that have made, I mean, this is an incredible difference in numbers. So
It is. And that's what we're seeing. And we get a lot of these counties that we have are bigger. So the resources are there. It's not just our attorney. There are other resources in the community coming, but we're finding with CPS, more attorneys in the courtroom mean social workers are understanding what a court is ordering, right? So that's cutting down months and months of extra time because they're getting reasonable effort sooner. So our attorneys are acting as not only legal representation for the agency, but liaisons between other attorneys such as parent representation, our caseworkers in courts. There was a lot of bridges that needed to be built as far as CPS and all the court staff and then the court. So I think we're just very grateful to see that and how an attorney is shaping. We can file motions. We're objecting on records. They are there every single youth court docket. I can count maybe on one hand that our attorneys have missed a youth court day. We try to fill in if not. So we do see that start to finish, that they're making sure that the court orders have the eligibility language that's required so they could get 4E funding, right? Because that is a big deal with funding. So we are making sure that timelines are being met because that youth court statute and the youth court process timeline is where it's at. So we're just ensuring that overall the court process is moving how it should. CPS is represented and understanding their role and needing help and just overall best interest of the child.
okay, let me ask you this. We changed a lot of these timelines like through the last several years. We've updated those. Right now, are the timelines, do you think, correct? Have we put those in the right areas? We changed some just this past year. Tell us what you, on the timelines.
I think so. The timelines of seeing permanency hearings a lot quicker, I think that has made a difference. Our attorneys are seeing that the families are being seen more. I think that's beneficial for reunification cases and not just termination adoptions. We do love to see and are able to see now those reunification cases. So I think getting the families in front of the judge more frequently, that accountability is there. I think the youth court timelines as far as the 6 months to 12 months, there's also some federal recognitions of timelines. I think they are working. And I think the more knowledge that every attorney has working in the system kind of holds everybody accountable for that.
Okay, all right. I know we've made changes, so if y'all would like to see any additional changes now that you've done this work, please let us know on that. So look, I appreciate y'all keeping it brief. This is incredible work. These numbers are very impressive. And thank you very much for doing all of this. And this is great stuff. So thank you. And we look forward to the additions that we need to make and the baby box legislation too. So we had some concerns when we passed it, but there was no way to know for sure until you got it out there and let it.
And we look at this as sort of fine tuning, and we've actually talked to the company in Indiana that started this. We had a call with their staff to get a better idea of how things work. So we've really spent a lot of time just wanting to fine tune it. And again, Lainey, she sees those cases. 2 were in the same county, as a matter of fact. 2 of the 3 were in the same county.
Well, thank y'all so much. And thank y'all for hanging in with us.
It was
all
our
of y'all.
pleasure.
Thank y'all for hanging in with us for so long today. Thank you very much.
Thank you all very much.
The motion? So moved.
Have a good evening.